and send you up there either today in the afternoon or tomorrow afternoon. The weather forecast looks horrible. So beware of sunscreen, sunglasses, and don't get sunburned. Temperature's a little cold, especially up there. It's pretty windy, but it's still a lot of fun. So the weather's good. Unfortunately, we probably have one of the worst winters right now with snow. It is what it is, but at least the weather is good. People are not familiar with it, so here's our town. You can't really get lost, mountains around. This looks pretty big. All I can say is I would not worry too much about on this side, because it just takes you longer to get to that cable car station all the way back there. Honestly, I would go more like this region, Rothorn or Gornegrad for those couple hours in the afternoon. And it's usually also not as windy as cold if you go all the way up there. But if you have a free day afterwards or so, definitely check that out. And you can ski all the way to Italy, and it's good food. Here's the town. South, the Matterhorn is down there. That's where you all came from. Zurich and all that is up there. So right now, you're at the Bahnhofplatz. That's the main place here in Zermatt. There's this one street with all the tourist trap restaurants and the super expensive watch places. It's pretty nice. Up there's the church, and there's not much going on behind that church. So stay in that region. We have 3 grocery stores. One is Denner. They're always open till 8 p.m. Super cheap. It's just past the train station. Go opposite direction on the left side. You will see it. We also have Coop, which is pretty good food. They also open till 8 p.m. It's right by the Bahnhofsplatz, right in front of here. And then you have Migros. I wouldn't worry about that too much. Just go to Coop or Denner until 8 p.m. The cable car station I was telling you about, it's a little bit far. It's back there. That takes you all the way up to Small Matterhorn. Gornegrad is right here, departing from actually just 100 yards from here. It takes you all the way up to Gornegrad. And there's also Sunek. It's a little walk, maybe 5 minutes, and then it takes you to Rothorn. If you have any questions about skiing, ask Patrick. He knows the ski slopes inside and out. Sponsors, thank you. Like a huge thank you. I know the difficult financial times, and you're still committed, and you're here, so I highly appreciate. We couldn't make the conference without you guys, and just a huge thank you, and I just please request that everybody checks out their new products and what they have to offer. And we're also very selective who is able to come. We truly believe that these sponsors are truly the best in the industries, and we work with them at Zermatt, and just thank you for being here. So we're right on time. Just want to introduce the organizers real quick. So my name is Oliver. I'm a flight attendant at Zermatt, and this is
Daniel. Daniel Cornell.
Andrew Sandhoft.
Patrick Wenger.
And we also have Matt back there. Everybody, thank you. If you guys have any issues the next few days, like you don't agree with something or whatever, just come one to us and we'll figure it out, we promise, okay? And for the people still standing back there, you guys have a chair, I promise. We have as many chairs as people in here, so don't feel like you paid a lot of money and don't even have a seat. We have like 10 seats up here, okay? Thank you.
So good morning and welcome. Now we get down to business. So my name's John Chatterjee. I am a consultant at London HEMS, and I'm going to be moderating most of the sessions here today. But you don't want to hear me. You want to hear the fantastic speakers we've got lined up and do the fantastic things that we have lined up. And one of those things is this afternoon there is the world's best ultrasound workshop right here in this room for those of you that don't want to go skiing. Okay, there is still also an ultrasound workshop here because the ultrasound workshop really, really is very good. Now, this morning, we're going to start off, as we always do, with the critical care session and start with into physiology, because I think you've all had your coffee and you're ready for this. So the first speaker is Professor Hugh Montgomery from UCH. His CV goes on for miles. He has done so much, but you don't want to hear me, you want to hear him, so I'm going to pass you over.
Good, thank you. I'd like to have the zapper. Thank you. Good, well thank you very much for having me. I will be quick so you're on the slopes in time. I'm going to talk about hypoxic adaptation. I'm going to take you from the physiology of environmental physiology and environmental hypoxia through to critical care. And when I was at medical school, I was told it was all easy. Short of oxygen, straightforward, you breathed harder, you made more red cells, your heart pumped harder, you grew more capillaries, and you chucked in more mitochondria. And we've lost the signal already. Anyway, I'll keep talking, because, oh, there we are. Breathing harder and more red cells. But here's an example of something that tells you that can't be entirely true. So this is the world record for static apnea. That's basically floating face down in a swimming pool, something that would have got lifeguards excited in my day. Anyone know the record?
Wow.
Okay, so 24.5 minutes of face down, not breathing. These guys and girls have worked out what to do, and a key part of that is they starve themselves. They starve themselves usually for 2 to 3 days before. Both of these things tell you that this isn't about more delivery. This has to be something metabolic. And Andy Murray in Cambridge and I wrote this hypothesis some years ago now, which turned out to be right, that starving is a metabolic adaptation. And it's driven through ketones. So when you break down fat, lots of fatty acids, you overwhelm beta oxidation, and you convert the fats into ketone bodies, acetoacetate and beta-hydroxybutyrate, which are burned in mitochondria in your brain, heart, and skeletal muscle, and a few other places as well. And that fuel turns out to be a metabolic switch. And it's used throughout the animal kingdom. This I put in because you'll see these on the hill, hopefully. These are marmots. They bury themselves in burrows, which they seal in the winter, and they become profoundly hypoxic. And they bump up their ketone levels very substantially to 5.5 millimolar. And at the same time, they reduce their energy consumption. This is the reef shark. It gets trapped in low spring tides and coral reefs. The oxygen tension drops dramatically, and it carries on as if nothing's happened, in part because it gets its ketone bodies, beta-hydroxybutyrate, up to 16.6 millimolar. And in fact, these ketones indeed are metabolic. They're anticonvulsants, as some of you will know, but they're profoundly protective against hypoxic injury. So if you are starving when you have your stroke or your heart attack, the injury you suffer will be dramatically less. And that's because they are metabolic regulators. Some of the early data from this was in the 40s, looking at hydraulic work in sperm. And if you get sperm to wriggle and you let them run on ketones, they wriggle a lot more for a lot less oxygen consumption. And you find the same thing with isolated working hearts. If you run an isolated working heart on ketones, you get a lot more work for 25% reduction in oxygen use. All of which is telling you that hypoxic adaptation, at least in part, is metabolic. So the question then is, how much of the remaining part is actually due to oxygen delivery? And as I'll hope to convince you, the answer is not very much at all. So these are data from our research expedition to Everest in 2007. The credit to Mike Grocott, some of you will know who led that expedition, an extraordinary man, and Dan Martin, whose blood gases I'm going to show you. This is 75 meters where our lab is, running up to past the South Col, and blood gases just below the balcony on Everest. And you'll find that the partial pressure of oxygen falls, as you'd expect. Arterial oxygen saturation falls. Hemoglobin concentration goes up, as you were taught at medical school. But if you calculate the arterial oxygen content, you'll find that when you've reached 7,000 meters, oxygen content is exactly the same as it was in Archway in 75 metres in London. So oxygen content hasn't gone up. And if we look, we published these data in the New England, if you look at the subjects that got their femoral arteries stabbed just near the summit of Everest, and look at the partial pressure of oxygen, there's Dan with a partial pressure of oxygen of 19.1 millimetres of mercury. So that's just over 2 kilopascals. Pretty low, walking around prepared to have his femoral arteries stabbed. Here are the arterial oxygen saturations. They're all terrible. There's Dan at 34% as an arterial oxygen saturation. But he's cerebrating, he's walking, he's running experiments on Everest. And when you think about it, of course, having a huge amount of oxygen, even if you had increased arterial oxygen content, doesn't make any difference at all if the driving pressure is so low. And you're at the very bottom end of the oxygen dissociation curve with a very low partial pressure. The driving force to deliver oxygen is pathetic. So you can have a massive quantity of oxygen sitting there, but you're not going to get it in. Cut a long story short, the business of increasing respiratory rate and driving up red cells is a response evolutionarily to bleeding. That's all it's there for. It's not about hypoxic adaptation. It's mainly about postpartum hemorrhage to let women who've bled after giving birth breed again. And you can see more evidence of this. This is work we did looking at genetics of Tibetan Highlanders versus Han Chinese, because this is humanity busting out of Africa, following coastal routes mainly. Not reaching Japan 35,000 years ago, but reaching this part of China around 60,000 years ago, and then moving into the Tibetan plateau probably around 35,000 years ago. Lots of time for evolutionary selection, and you can look at the relative frequency of various alleles, and you'll find that some are much more frequent in Tibetans than they ought to be. And when you look at what those alleles do, this one is the biggest one. It's the first we found, and it's been replicated a lot, EPAS1. That regulates a product called HIF2 alpha, and it is associated with lower hemoglobin mass. The Tibetan adaptation to hypoxia is actually selection pressure to get rid of red cells, because having high viscosity is really not a good idea. So, is it all about oxygen delivery? Not really. We also know that your contractile function, when you're up on the hill in a few days' time, your cardiac contractile function will get less, your stroke volume, stroke work will lower, your capillary density will fall, and you'll strip out mitochondria. So everything you were taught at medical school, at least in this regard, was nonsense. Again, this is all suggesting that adaptation to hypoxia is metabolic. And you can see this again in the animal kingdom. Here are a few animals. You can give yourself a beer if you can work out who they all are. This is an Oscar fish, lives in the Amazon. Amazon gets hot, oxygen tension falls, and it has to adapt. This is the Crucian carp, Northern Europe, lakes freeze over, oxygen tensions fall, it has to adapt. This is the oyster toadfish, gets trapped in mud, no oxygen pretty much, and it has to survive. And this is Squalus, which is the reef shark. And in every case, massive reduction in muscle protein synthesis, massive reduction in protein synthesis, reduction in protein synthesis, reduction in protein synthesis. All of these animals, as a primary adaptive response, switch off protein synthesis. And you can see the same thing happening in humans. All of you have climbed at high altitude, unless you're really weird, will lose a lot of weight, no matter how much you eat. And that was me just before Choi Oyu, and that was a few weeks later. I was 14 kilos down. I'm one of the more extreme weight loss groups of people. But if you look at our climbers on Everest, all those that just were pottering around at base camp eating ham and cheese, they've all got substantial reductions in lean muscle mass, despite eating what they like. They're losing around 10% of their muscle mass. And this, just as those animals, is highly adaptive. This is not maladaptation. This is the normal response. And you can see that it's programmed. Here are some anabolic stimuli for laying down muscle. When you eat, it provokes you to lay down muscle. If you go to the gym and do some weight training, you lay down muscle. And here are some hormones like insulin-related growth factor. Here's an inhibitor. Here's hypoxia-inducible factor, or HIF, which you will all induce when you go up the hill today. What that does is it activates AMP kinase, and those things switch off tuberosclerosis protein and mTOR. Essentially what that does is switch off these pathways. Net result is you switch off anabolism. When you're at high altitude or hypoxic, you can't lay muscle down. Meanwhile, the 4K transcription factors through MRF1 switch on catabolism. So this is a very programmed response to hypoxia. You don't make muscle, and you actively remove muscle. Why? Well, less muscle means less weight to carry around for sure. Reduced effusion distances, possibly, but mainly this is about maintenance costs. Maintaining protein is energetically very expensive. In an isolated thymocyte, 92% of the oxygen consumption is due to protein synthesis. So by switching off muscle synthesis, you're saving on an oxygen requirement. Massive reduction in maintenance costs. So what have we learned so far? We've seen to have a metabolic response to hypoxia. It seems that you're switching off metabolism. And as we'll see, you switch to anaerobic metabolism preferentially, and you improve the efficiency with which you burn oxygen. And we first discovered this now going back a long way when we were looking at angiotensin-converting enzyme, or ACE. Here's the ACE gene. There'll be an exam on it later. You'll have to draw this. All I actually want you to remember is that there's either an extra bit of DNA or there's not. If you've got the extra bit, you have low ACE activity. And since you've all got two alleles, I seem to be talking to myself now. Since you've all got two alleles, 25% in this room have got two I alleles, got low ACE activity. Half you an I and a D, moderate ACE activity, and half of you have two D versions, or sorry, a quarter of you, and you'll have high ACE activity. And you can work out which you want, because here's that normal distribution in 1,906 normal healthy volunteers. And if you look at high altitude, and these are people who are regularly beyond 7,000 meters without oxygen, very few DDs, a massive push towards the advantage of the I allele. I was talking to someone just now who knows that route. That's the route up from the Goûter hut on Mont Blanc. And if you take DNA from people at the hut, and when they come back saying, hey, did you get to the top? What you find is that the DDs are at a very substantial disadvantage. About 12% of them don't get to the top, and all of the IIs do. Some of you may have climbed this. This is Kilimanjaro, and if you look at people doing a 6-day ascent there, you get the same thing. All of the IIs get to the top, the DDs don't. You find the same in hypoxic patients on intensive care in terms of survival. This is ARDS mortality, 5-fold greater if you're a DD genotype than if you're an II. So when you're beating yourselves up about why one person died on the IT and one didn't, just remember you're being trumped by a 500% difference based on one genetic marker. Same thing with hypoxia and meningococcal sepsis. Those that are well enough to stay on the ward, 10% in the DDs. The ones that need to come to the pediatric ITU, 35% are. And half of the ones who die are DD. The reason? Metabolic efficiency. Here's a skeletal myocyte, and we've stained it with a fluorescent dye called TNRM, and that glows depending on how well coupled the mitochondria are. So how leaky they are. If you reduce the leak, they glow more orange. If you add an ACE inhibitor, that's what happens. So low ACE, which 25% of you in this room are genetically endowed for, have better mitochondrial coupling. And that's partly because you're switching off the pathways by which protons can leak through the membrane using uncoupling proteins. We strip those out. And I won't bore you with the details of the slide, but just to say that ACE is a regulator of the uncoupling proteins. Right, we've got a long through so far. Basically, hypoxia isn't about adapting by increased delivery, it's about metabolics. Some of it's to do with ketones, and a lot of it is to do switching off use, protein synthesis, and increasing efficiency by changing uncoupling proteins. But what about critical illness? Well, Zudin Puthacheri, some of you will know, who's a fantastic clinician scientist, did this work when he was doing his PhD with me, biopsying patients day 1, 7, and 10 on ITU. Here is a representative piece of muscle on day 1 of a 35-year-old with 4-organ failure. Lovely round myocytes, evenly staining for protein, no nasty neutrophils in there, it looks lovely. Day 7. The cells have lost a huge amount of volume. They've lost a lot of protein. It's not staining. And you've now got an inflammatory cells coming in here, stripping out macrophages, stripping out mitochondria, stripping out myocytes. If you look at the percentage loss of ultrasound of rectus femoris, that muscle there, using cross-sectional area, you can see that in 7 days it's down 12%. If you look at the fiber cross-sectional area, so you're getting rid of edema as a factor, you're down by nearly 20% of myocyte cross-sectional area in 7 days. But if you look at the amount of protein normalized for DNA, it's down 30%. This is why your patients are so weak on ITU when they're critically ill. Within a week, they've lost a third of their muscle protein mass. And they're doing it not because something's gone badly wrong. They're doing this as an adaptive response to hypoxia because they're lowering energy demand. And we also know as well that to lower energy demand, we're switching metabolic substrates because fat is a very inefficient fuel. It's a whole string of unoxidized carbons after all. And if you look at Sherpas, again, work we did with Andy Murray, taking Sherpas and lowlanders going to altitude from Kathmandu to Everest Base Camp. We looked at a particular molecule called PPAR-alpha, peroxisome proliferator activator receptor, which is a regulator of fatty acid oxidation. And you can look at the genetics of Sherpas, who are essentially Tibetans who come over the hill, versus lowlanders. And I don't expect you to understand the genetics. These are just 3 gene markers, and the slide's gone a bit weird. But, and in fact, it's not going to show you. What that slide was meant to show you is that there's a tremendous difference in the presence of various allelic markers. The genetics of PPAR are very different in Sherpas than they are in lowlanders like you and me. And in fact, that's associated with lower expression of PPAR. Here are we lowlanders, here are the Sherpas. And not only is it associated with lower gene expression for PPAR, it's associated with lower expression of the enzymes that burn fat. And if you measure the fat burn, you find that we lowlanders, that the Sherpas are burning less fat than we are. If you look at intensive care then, what's happening there? Well, it cuts a very long story short. Let's just remind you, here's hypoxia via HIF, and what it does through those pathways is it switches on muscle protein breakdown, that's the catabolism there, and it switches off the anabolism. If you do a network of gene expression, what you find, here's HIF. It may well be switched on by hypoxia, but it's mainly being switched on by pro-inflammatory cytokines and lactate. So HIF is badly named. It's not just a hypoxia-inducible factor, it's a metabolic regulatory factor. And when you're critically ill, that pathway is saying, I'm in metabolic trouble, switch off oxygen use. And as a result, cytokines and lactate are driving HIF and switching it off. Here's FOXO, the bulkhead transcription factor, also being directly activated to switch off anabolism, activated by cytokines. Here's HIF as well, switching on PGC1 alpha, or switching it off rather, so that's stripping out mitochondria. And down here, unrelated to everything, are the fats you're giving from enteral feed and TPN. So it doesn't matter much how much fuel you're giving, your critically ill people can't burn it. It's got nothing, so you cannot keep your patient maintaining muscle mass by feeding them. It's irrelevant. Because beta oxidation is switched off, mitochondria are removed, and ATP production is massively reduced. And you are switching to anaerobic metabolism, even in the presence of plenty of oxygen. HIF is switching on GLUT1 as a transporter, shipping in more glucose, the glycolytic enzymes are going up, pyruvate's going up, but you're blocking pyruvic dehydrogenase and diverting that pyruvate down to LDH and lactate. So lactate synthesis is also a normal adaptive response. So finally, given what I've just told you, given that the response to critical illness is to not use fuel, not use food, not use fat, try to reduce oxygen use, does it make sense to do all the things we used to do? In my youth, we used to drive oxygen delivery. Got to get more oxygen in, it's about more delivery, until the Bart's team did the study and showed that that was associated with an excess mortality. Transfusion. We always used to transfuse because clearly it was better to keep oxygen delivery up. until all the studies showed that there was an excess mortality. Growth hormone. Let's give them growth hormone. Maintain that muscle mass. Excess mortality. Feeding. We're all told it's a mantra, right? Get that nasogastric tube down. If they can't tolerate the food, shove it in them anyway with a neckline. We've never got any evidence that early feeding makes a difference. Most of the signals show harm. And finally, to close the loop, if your body is trying to starve itself, why? Part of it comes down to ketones, not just as a metabolic switch, because these are powerful immune regulators. My grandparents used to say, you feed a cold and you starve a fever. If you're critically ill, you don't want to be fed. And why? This paper in Nature Metabolism showing ketones improve outcome in COVID in every animal model shown, and they functionally reprogram T cells. So ketones regulate your immune function. So if you were to be very ill today and you couldn't go out hunting and you're going to get eaten by the saber-toothed tiger, you're going to sit under a tree and shiver and feel poorly and starve, and that is a signal to reprogram your immune function. So we've got it wrong for years. So to close, hypoxic adaptation is primarily metabolic. Lactate and cytokines play the role in critical illness and driving that. And maybe we should be thinking about less, not more, in terms of driving oxygen delivery and nutrition. Thanks very much for listening.
Stay up here. That's fantastic. Thank you so much. Ollie, are you coming to tell me something?
30 seconds of more logistics. So first of all, we have toilets right here. Emergency exits, there's one behind here. So basically if something happens, we're just going to rip this down, and there's a door, or just exit that way. Don't forget to sign up for the fondue. Yeah, and the coffee machine. And unfortunately we have to unplug it during the speeches because it's live stream and they can't hear much during the live stream. So yeah, just wait for the break.
Now, I love the way we go micro to macro here. So we're going to go back from the coffee machines and the emergency exits to this talk. Are there questions? Because I found that absolutely fascinating. There should be someone with a roving mic running up to you. Just put your hand up. No, there he is.
Yeah, so with early and late feeding in the ICU then, do you have any good ideas of how to tell when the patient is anabolic or catabolic? Or is it just clinical, or do you have markers? Do you have...
It's a brilliant question. So if you couldn't hear it, the question was, have we got any markers to know when to feed, when they're anabolic, catabolic? No, we don't. And we're looking for those. If you follow them through for the first 14 days, it looks in most people who are critically ill, at least if they're not dead by then, that they start revving up anabolism at the same time by about day 10. So I view that as being at the traffic lights, your foot on the clutch, foot on the accelerator and foot on the brake, revving, waiting to go. And at some point thereafter, you switch off the anabolism and then you switch off catabolism and the anabolism runs away. So it seems in most patients it's happening at around day 10 if they've survived that acute illness. But we don't yet have a biomarker for doing it. We were using radio-labeled isoleucine and so forth there, which isn't a useful tool. So no, we don't have a marker, but my guess, if you made me make a choice, and believe me, I'm not telling you not to feed people, okay? That would be wrong on an N of 1. But if it were me, and sometimes that's helpful, if I were critically unwell and end up on your ITU, I'd rather you didn't feed me, please, for about day 7. I think I'd be happy to be run catabolic. And Zudin is actually doing the trial of giving people ketones instead of fat and sugar. And that might actually be the way of doing it, actually just give people the ketones as fuel.
Fantastic question. Over here on the left, there are a couple of questions.
Hi.
Hi.
Thank you for this lovely talk. Would you argue that there's any benefit in giving critically ill patients in the ED, for example, ACE inhibitors? Is there any study?
It's a really good question, and it's a great shame, because when you're in research for long enough, you realize that the agenda is largely driven by drug companies. Not in a bad way, it's just that when there's a product on license, money flows in. And when the product's coming off license, the money disappears. Even in grants, people lose interest in funding. So unfortunately, all of the ACE inhibitors were coming off patent when these sorts of data were appearing. But their collaborators were able to do a few studies. So for instance, in isolated arms, post-cardiopulmonary bypass in people on cardiothoracic units, if you infused an ACE inhibitor down the brachial artery on one side and not in the other, there was a powerful protective effect on muscle loss, actually, on that side, and in oxygen utilization efficiency. So it strongly suggests there would be a benefit. We tried to get the money to run the trials. Clearly there are dangers. I mean, you're going to drop the blood pressure, right? You're going to have to make sure someone's well filled if you're going to give them a shot of an alloprolat IV or something equivalent. There may well be advantages, but I wouldn't advocate it right now for the reasons we've just said. We have to do the trial, really. My guess would be it would work.
Interesting. And, oh, yeah.
That was a beautiful talk. Could you please comment on mobility and physical exercise in the intensive care unit with respect to muscle mass and muscle strength? Thank you.
Yeah. So this is, I mean, we're all at this, aren't we? Not just prehabilitation, but early rehabilitation. In the very early phases, A, your patient won't want to do it, and B, it won't work. For the reasons I've just described, early on in critical illness, you could load that muscle as much as you like. You could use IGF-1 or growth hormone, and it's not going to make any difference. I mean, it might kill them a bit quicker, but it's not going to improve them. The time to do it is when the patient is no longer got this huge pro-inflammatory milieu, and they're able to engage in the process. But it's going to take time. That's the issue. I think we're not just looking at a deconditioned person here. We're looking at people whose, the Z bands have got virtually nothing coming off the sides of them, really. So I'm in favor of exercise and retraining, but I'm not in favor of it happening too early, because I just don't think it'll work.
As you come off the clutch, some food and some exercise.
Yes, together, yeah. And the other part of what is we're all, I think, perhaps interested now in normalizing ITU care, so trying to get people to have not just have this 24-hour clock that just rolls through with no cues. And of course, feeding is one of those cues, socially as well as in every other regard. But also, there's an issue called muscle full. If you expose people to high levels of amino acids continuously, the muscle can't recognize amino acids are there, and it won't absorb them. So continuous feeding is a pretty crappy way of actually trying to rebuild muscle. What you want to do is to give it intermittently. Now, we failed to show the benefit to muscle growth. We've done that trial in critical illness early on, but then I'm thinking it was probably the wrong study, because early on, you wouldn't expect it to make any difference because they're not anabolic anyway. When they do become anabolic, almost certainly giving intermittent feeding is the way to do it. That trial we've done does show it's safe. You can bolus feed 3 or 4 times a day. It's fine. It doesn't wreck your blood sugars. It doesn't mean people vomit and aspirate the whole time. And if you look at elderly people on elderly care wards, or you look at stroke patients, their anabolic response is much greater when they're intermittently fed than continuously with nasogastric feed. So I think you're right. I would move to, as soon as you can, I would move to intermittent feeding and exercise training.
Oh, what do you think about performance enhancement? So I was especially thinking about those DD folks, like, loading up on Diamox or something before they summit. Is there any sort of evidence to support that?
Yeah, the old triple D back in, most of you are too young to remember the days of triple D. I'm sure you are too, but that was basically Diamox, dexamphetamine, and dexamethasone, which was the way to get to the top of a hill really quickly. The interesting part seems to be that for the DDs, and I'm a DD, and I have climbed the odd big hill, we do seem to play catch-up. So it's not necessary that you just can't get there at all. It's just if you give yourself long enough, you can. So if you look at people who are trying to climb Killian in 10 to 12 days, the II advantage is to a substantial degree lost. We just need a bit more time. But as to whether we cheat, I don't know. I don't know, I'm a bit of a traditionalist. I don't take those sorts of drugs to get to the top of hills, partly because I'm worried if something goes wrong, I've already shot the bolt. I've got nothing in the backpack that will get me out of the hole I'm in. Yeah, but I'm sure it would give you an advantage to getting up there. Good. Is that us?
Brilliant. Thank you.
Good. Thanks for having me.
Thank you so much. I absolutely love it when I don't have to do very much, because a fantastic talk, fantastic speakers, and fantastic questions means that I just get to do the easy bit. So, well, having said the easy bit, our next speaker is a Norwegian. Now, I have huge sympathy when Europeans have to pronounce really complicated Asian names. And now I'm getting it back the other way, because I'm just going to try and get the name right. The rest of it is quite easy, but Knut Kvernebo-ish. It's got lots of consonants in the letter in the name. But pronunciation aside, we're going to stay with the theme of going into the physiology and the micro approach before we sort of move on to a bit more of the practical approaches and talk about microvascular oxygen delivery. But he was a professor at Oslo University for many years and has retired from his surgical practice and to form a company called ODI Medical, and continued diving into the research. And again, I think you want to hear from him more than me.
So the name is Knut Kvernebo. When I worked in Boston, all the nurses had a problem, so I was only named Dr. K. So I will talk about microvascular oxygen delivery. And I will start with the big perspective, from the Big Bang to circulatory failure, monitoring of circulatory function, and try to define what is the definition of circulatory failure. We will talk a little about basic microcirculation and also diffuse reflectance spectroscopy. So I heard a lecture some years back from Professor Jean-Marie Lehn, that was a Nobel Prize laureate in chemistry in '87. And his talk was really interesting. So he told us that when everything started, it was a Big Bang. When the Big Bang happened, it was no material in the universe. It was only energy. And when the bang happened, the expansion of the universe started, and then you had the reverse of the Einstein equation. E is like mc in second potency. So material was created from energy. And then at the time when it was only energy, laws of nature of energy were there. And when material started to form, it aggregated to create atoms, and the laws of atoms, like we know the periodic system, are laws of nature, but they have to be compliant with the laws of energy. And then when the atoms created molecules, then you have laws of chemistry, and that was what Jean-Marie Lehn said, that was the creation of chemistry. But the laws of chemistry have to comply with the laws of atom and the laws of energy. And if we follow this hierarchy of laws of nature and go into what happens in human physiology, we know that after 10 billion years, life was created on Earth, and life can exist based on anaerobic or aerobic metabolism. And the top of hierarchy of laws of nature of physiology is delivery of oxygen to all cells of the body. And if we don't deliver oxygen, cells will stop functioning and then eventually will die. And this is the example. If you have a premature child where it's no genetic defects, the only question is nutrition and delivery of oxygen by by the microcirculation. So what is the cycle of oxygen in the body? It's the molecule that created the life, and all of us know that oxygen is uploaded in the lungs. It's transported by the force of the heart, and it is delivered by the microcirculation. And we have a lot of monitors in standard clinical practice for assessing and monitoring respiratory function and central hemodynamics. We are looking at blood gases, pulse oximetry, pressures for assessing central hemodynamics, and we can also look at levels of lactate in the body as an indicator of anaerobic metabolism. The interesting thing is that the screen that we use today looks really fancy and nice, and when people enter an ICU for the first time, they are really impressed of the technology. But this screen is showing exactly what I learned as a student 50 years back. It's nothing new in this screen, except for nice presentation, nice colors, but basically it's a massaging of concepts that are 100 years old. And it's very useful, of course, and we have added also 50 years back the possibility of using ultrasound for assessing heart function. But all what we see here are monitoring lung function and heart function, and don't say anything about the delivery function from the microcirculation. What about blood lactate? The classic situation is if you have an embolus occlusing the bifurcation of the aorta, then you enter the hospital, the patient, with numbness in the feet and no pulse in the feet. What do the vascular surgeon do? They remove the clots, and if they are inexperienced, and I've seen that happen, they are very happy when they reperfuse the limb. Before they did the surgery, lactate levels were normal. After reperfusion, 30 seconds and the patient have heart arrest because of the enormous washout of lactate. So lactate is not a good indicator of the systemic circulation and the systemic nutrition of cells. So this is a case example. Extracorporeal membrane oxygenation for acute heart failure. And we all know that it's easy to put a cannula to the heart, drain the heart from the veins, have an extracorporeal pump, an oxygenator, and we have pretty good control. And you can monitor the situation, turn on and off the pumping capacity and so on, and it is a fantastic device. But what about results after putting patients on ECMO? So short-term survival is really poor. And it's an extremely expensive treatment. And average cost in US is really, really expensive. And average days of on ICU and ECMO in Norway is up to 9 days, and it's an enormous consumption of resources, of personnel, and drugs and blood. Accumulated 1 year survival is 15%. And that is really shocking. And the ones that live after 1 year, we don't know whether they are in elderly people's home, with whether they are mobile or have had mental problems or moving problems and strokes. And if we think about the investment in terms of money and resources, it is really, really appalling. So we have to do something. This is one case of a patient 10 days after ECMO, a lady in her 40s that we operated. And at that time, I did a lot of studies on microcirculation, so I said that I won't take part in decision-making about this patient. And of course, a very nice thing for the patient is that the cardiac surgeon has enormous ambitions on bringing this patient through the disease. But this is the situation after 10 days. Although blood pressures were fine, output, oxygenation, everything was fine that we could control on the monitor, but the patient looked like that. And it's really, really, really bad. So what is the definition of a failing circulation? So as a simple surgical mind, I have to do it simple. So what is human life in terms of biological human life? The sum of the function of all cells in the body, and our body is extremely complex. We have 10 into 14 potency of cells, and all these cells are dependent on delivery of oxygen to function. So the reasonable definition of respiratory circulatory failure is failure to deliver sufficient oxygen to maintain life and function of all the cells of the body. Everybody would agree. And it can be a local or a systemic failure. So what about monitoring? And what can happen when we don't deliver from the microcirculation? Of course, if we have a reduced lung function, then we don't deliver appropriately. We have pretty good control of this in clinical medicine. If we have reduced cardiac function, then we don't deliver properly, but we have pretty good control. But what we do not have any control of in clinical medicine is how do the cardiac output being delivered to all cells of the body, to the distribution of cardiac output to all kind of tissues in the body. And we do not have any proper biomarkers for the capacity for delivery. So what it's all about is this situation. This is a film of a microvascular bed. And the first time I saw this film, I thought it was really fascinating, but it is a film of a chaos system. It is erythrocytes moving in capillaries, but the capillaries vary in size. The flow direction varies from vessel to vessel. And I had two immediate thoughts when I saw this film. How can I quantify what happens in this chaos system? And the second question is, how would it look like if the patient were in circulatory failure, for instance, heart failure? And I didn't know. And I tried to look seek in the literature, and I couldn't understand and find how would it look if the patient were in severe failure. So, in a way, delivery of transport and delivery of oxygen is based on a well-balanced transport system, and we don't deliver if we have lack of moving transport vehicles, and it really creates a lot of regulation here. And in some cases, it may be impossible to transport at all, like in this road on the west coast of Norway. So, some few words on basic microcirculation. This guy is a very, very important person in history of medicine, and very few doctors know anything about him. He was the Nobel Prize laureate in 1920, and he understood that the oxygen molecule has a very poor diffusion capacity in human tissue. And he proposed that if you take a cross-section of a capillary, oxygen will diffuse out of the capillary, but it can only diffuse to a certain extent. So a cell located here can never be nourished by this capillary and perfusion in this capillary. And from his Nobel lecture, he proposed that the tissue could look like this, where we have different capillaries, and we have a cylinder, a Krog cylinder, surrounding each of the perfused capillaries. And then it's obvious that if we occlude 3 of these capillaries, but double perfusion in 4, we will still have a problem with cells dying, because these cells in these cylinders cannot have nutrition and oxygen delivery from these capillaries. And what is the diffusion capacity? And that is in the range of 150 microns. So when oxygen is leaving a capillary, it can give nutrition to cells in a diameter of approximately 150 microns. And I thought that I will try to describe a system describing morphology, perfusion, and oxygenation. What about tissues for examining systemic circulatory failure? And we know that, 5 minutes left, we know that we may get white from fair, but we can also be blushing because of we are embarrassed. So I worked on a condition called erythromelalgia and learned a little about what is the problem with people with hyperperfusion in limbs, but still they have hypoxia in the limb and get hypoxic ulcers. So the skin has a nutritional part because the consumption of oxygen is making new cells for epidermal cells being worn off. But deeper in skin, we have a thermoregulatory plexus. And in my hand now, approximately 80% of perfusion in my hand is taking place in the radiator, and only 10 to 15% is taking place where we deliver oxygen. And here oxygen extraction is high, here it's very low. What about regulation? Precapillary sphincters, everybody have seen them in the textbooks, they don't exist. They don't exist. So it's a much more sophisticated system regulating microvascular perfusion. And in this figure, the radiator is regulated by autonomic nerves. This system is only regulated locally by pericyte activity. Heterogeneity and microvascular perfusion. This was a guy of 23 years with acute heart failure, ventricular fibrillation, cardiopulmonary resuscitation without DROSC, and ECMO after 80 minutes. We should probably not have put him on ECMO, but when you look with a microscope, part of the situation and microcirculation looks fine. This is normal. But here, some millimeters to the side, here is hardly any perfused capillaries. So this guy dies because of maldistribution and malregulation of microvascular perfusion, and he dies because of the cell death load and not because of areas that is still viable. So this is the two last slides. It is a technology called diffuse reflectance spectroscopy. I will come back to this technique tomorrow. But this is a kind of proof of concept that we did on patients with COVID-19, 40 patients, hospitalized at MGH. And when we have developed a technology that can measure what is the saturation of erythrocyte in nutritional capillaries in the skin, and that is what I will talk about tomorrow, we see that healthy controls, they have a saturation, 100% saturation on the arterial side. In the microcirculation, they have a 55% saturation. But the ones that die from COVID, they have an average saturation of 20%, and that is in spite of excellent treatment with respirators and oxygen for the lung failure. So I think we have shown that COVID fatality is not only caused by lung problems and uploading, but also by dysregulation of the microcirculation and lack of delivery. And I will tomorrow also talk a little more in detail about Fick's law of gas diffusion and this technology called diffuse reflectance spectroscopy, where the main message is that the driving force for oxygen to leave a capillary is the partial pressure difference on the two sides of the capillary membrane. And I think we shown in these COVID patients is that we can estimate that they are hypoxic in the tissues. So I think that we have developed a non-invasive technology for assessing tissue PO2, and that is what I will talk more about tomorrow. Thanks.
Thank you very much. That's absolutely fascinating. Any questions from the floor? Well, whilst I think of your questions, I've got one for you that I wanted to ask. So, were you talking about ECMO and the microvascular flow? ECMO obviously is a non-pulsatile pump, and whereas the normal physiology is a pulsatile pump. Do you see any differences in the microvascular flow?
Yeah, for sure. We've done studies with at Cleveland Clinic in pigs and put them on continuous flow pumps and also on a new pulsatile pump that mimic normal pressures. And we have assessed what happens in the microcirculation, and with a non-pulsatile pump that we use for ordinary clinical work, you dysregulate the microcirculation. So instead of having an optimal velocity of erythrocytes in the capillaries, you have velocities all over. A big percentage do not have any flow velocity at all, and certain number of capillaries have an extremely high perfusion velocity. So it means that the regulation system fails when you lack pulsatility from the continuous flow pump. And that, I think, will really revolutionize ECMO treatment in the years to come, that we have to change the pumps.
I mean, I think it's absolutely fascinating, both your and Hugh's talk, looking at the natural physiology versus, it feels like we come to this very delicate lattice of systems that works in the human body normally, and we come in with a sledgehammer and then say, there you go, we've upped this, it's going to be fine. And obviously it's not. How far do you think we are away in months, years, decades from actually having useful monitoring to give us those feedback loops for the things that you've both been discussing?
I'm really glad you asked these questions, because that is why I started a company some years back called ODI Medical. We are working on a handheld system to use bedside that can assess microcirculatory function. So that will be the topic of my talk tomorrow. And when it comes to ECMO, I worked with this pump that is developed at MIT in Boston. and it's basically a pump that is developed in cooperation with Bose sound speakers, because Bose has a system for moving a membrane, and the MIT people have developed this into a system where you can program the movements of the pressures. And we have tested that out in pigs at the Cleveland Clinic, and I think the first in human studies and applications will be done within a year or two.
It's fascinating. Anyone from the audience? Well, in that case, thank you so much. We look forward to your talk tomorrow.
All right, I started getting annoying, right? So first of all, Wolf Houts, is he here? Wolf Houts? There's like 2,000 pounds of equipment just got delivered for you. Just hit me up. Broke my back. The second is we have a break from 10 to 10:30. Whoever, a couple guys and ladies approached me for renting skis. Whoever wants to rent skis, meet me outside 10 o'clock and we'll bring you somewhere. It takes you like 4 minutes to get the skis. Another thing is coffee machine will be back in operations at 10 o'clock. We unplug it again at 10:30. And fondue, right? Sign up. Yes, sir. Ski pass, yes. So you can basically get ski pass everywhere, like everywhere there's a cable car station. They're like machines there, like 28 different languages as well. Yes, and half-day pass, good one. 12:15. They start 12:15. Swiss watch. If you want to buy them 12:14, doesn't work. 12:15. Okay. Any other questions? You guys are so shy this morning.
Right. Thank you so much. So, we've started off with the physiology and some of the deep stuff behind what we do practically. Our next speaker is Jean-Louis Vincent, and he actually, it's very interesting. The speakers this morning are representative of the conference as a whole, coming from different countries, different backgrounds, and different disciplines. And I think it really sort of, shows what we do as a conference together here. But Jean has been past president of the European and World Societies of Intensive Care Medicine. He's an intensive care and emergency physician and a professor in Brussels. And he's going to talk a bit more practically about the approaches and using some of the things that we've talked about in how you look at someone and treat someone in the early stages of resuscitation with sepsis. So I will hand you over to him.
Thank you. Well, thank you very much indeed. Thank you for having me here. It's a pleasure to add a little bit of Belgian touch to this meeting, and I love Zermatt. So I'm very, very happy to be here with you. And it's my pleasure to speak very practically about how to manage the patient with, let's say, septic shock when we see him or her in the emergency department. First of all, let's go to our latest consensus concepts. That sepsis is organ dysfunction secondary to a dysregulated host response. Some years ago, we would have said excessive inflammatory host response. But no, it's pro-inflammatory and anti-inflammatory at the same time. So the criteria, it's basically a severe infection plus organ dysfunction. It has always been like that. We didn't change it with our most recent definitions. Hippocrates coined the term sepsein, which in Greek means putrefaction. He described a state of putrefaction without knowing much about infection, of course. But this is a paper I just published 10 days ago, making the distinction between the mechanisms and the criteria. For ARDS is the same thing. People speak about the new definitions of ARDS. No! ARDS has always been ARDS. We may change the criteria somehow, especially now that we use high-flow oxygen, but ARDS is ARDS. Myocardial infarction is myocardial infarction with or without troponin levels. Myocardial infarction existed before troponin was available. So, this is my pyramid. It means that when we speak about an infection, there is some host response. Otherwise, it's colonization. The Americans spoke about SIRS, saying that's a sign of sepsis. No. SIRS is the host response being part of the infection. How do you recognize infection? Well, fever, altered white blood cell count. Okay, that's SIRS. When we speak about sepsis, it's one step more severe. Now we have some degree of organ dysfunction, and of course, when there is septic shock, then there are signs of altered tissue perfusion and increased lactate levels. So, very importantly for everybody, especially those working in the emergency departments, we all know that, but sometimes the patient comes with an obvious infection, and we wonder, isn't it sepsis? Let's look at the organ function. But sometimes, and it's more challenging, the patient does not come with an obvious infection. The patient is obviously critically ill. The patient may be in shock. There may not be so much fever. The signs of infection may not be so evident, but we wonder, don't you think this may be sepsis? That's where a sepsis marker can be actually particularly interesting. So when we speak about organ dysfunction, we think at these 6 organs, right? We could add metabolic, but how can we assess it objectively? It's a bit difficult. Whereas circulatory, respiratory, neurological, hematological, renal, hepatic are the 6 organs we can actually explore quantitatively. During our latest consensus conference, my colleagues loved the development of the QSOFA. I'm not so keen. I'm not really very much supportive of QSOFA. If the quality of care is not very good, you can remind people that tachypnea is important to identify. Hypotension is important to identify. Some alteration in the mental status, disorientation, confusion, in a patient who was not like that before, is important to identify. Okay, that's fine. But I'm not sure we really need that kind of simplification, because at the end, the QSOFA is certainly not specific for a sepsis. It means that the patient is very ill. It could be any form of shock. In trauma, I like this paper published already several years ago, but it shows that, of course, the patient with polytrauma may have some hyperventilation, may have some hypotension, and may have an altered mental status. Of course, massive pulmonary embolism, the same thing. Severe heart failure, cardiogenic shock. Actually, any form of shock, if we think about it. Okay, sepsis management. I always like to keep the 3 components in mind. I don't mix them, even though we need to apply them together. Although in the emergency department, it will be primarily infection management and hemodynamic management. I will not speak about corticosteroids because this is not really so urgent. I just revisited it in a paper which is open access if you are interested, but it's the same thing. I like to have this graph in mind. And once again, hemodynamic resuscitation, infection control should take place together. But these are different things. So infection control, do you believe that antibiotics work? If you say yes, then of course we need to start early and give the right antibiotic. It seems very, very logical to a Belgian guy like me. So timing is crucial. Yes, of course, especially when the situation is very severe. Of course, if it's just an infection, you have time to choose the antibiotic and give it. But when it's septic shock, think at meningococcemia. Wow! Every minute will really count. So let me just cite one recent paper showing that there is not really a time limit. The 1 hour time limit is really artificial. But if you look at this paper indeed, and it's a very large collection of data, more than 3,000 patients from 19 hospitals in Korea, you can see that without septic shock, it doesn't matter so much. In septic shock, antibiotic administration is really very urgent. And importantly, we do not always speak about it. Nurses should be involved and should be concerned about this. Because too often the doctor feels, oh yeah, I ordered the antibiotics, I'm very good. But then the nurse is very busy with many things. And you say, oh, what about the antibiotics? Oh, I have only 2 hands, you know. You ask me this and that, I have no. No. There is a priority there, and we need to have a team approach. We need to talk about it in our local seminars. By the way, we all know it's important to take blood for blood cultures before we give antibiotics. I like this study showing that if you don't take blood before, but just after, you can actually miss quite a number of microorganisms. So don't say, I will just give the antibiotics and we'll take the blood cultures. No. We need to take the blood for cultures before. So, to make a long story short, the sicker the patient, the more urgent the antibiotic administration. And the choice is important too, because obviously we want to choose an antibiotic that will be effective against the incriminated microorganisms. But it doesn't mean that we need to bombard patients with broad-spectrum antibiotics in each case. As you know, in the US, it's a big thing now, because with these 1 hour severe sepsis, septic shock, early management bundles, which can even result in more income for the hospital, people tend to do that. And this is a paper that was published just last week. I urge you to read it because it's very well written. It's a nice short review saying, you know, there is no evidence that such a bundle decreases mortality. But there is clear evidence that you give more broad-spectrum antibiotics and more fluids to patients who may not need it. Because there is also this recommendation to give 30 cc's per kilogram of crystalloid solutions, which comes from nowhere. And the authors very nicely outlined that we should perhaps be evaluated upon outcomes rather than just the initial management. Look at this paper, very good, the same Dr. Reed. Published this paper showing that if you start with the wrong antibiotics, the outcome is worse than if you start with the good antibiotics. Well known for a number of years. But this is new. It is that if you bombard with broad-spectrum antibiotics, when it's not necessary, the outcome is worse than if you select the appropriate antibiotics. Why? There can be a number of reasons, but it's primarily because of the risk of development of resistant microorganisms, maybe also antibiotic-related toxicity. So, I give antibiotics as soon as possible. The more severe clinical presentation, the more urgent the antibiotic administration, but antibiotic therapy should cover all likely pathogens, not less, not more. And of course, later, when we have the results from the bacteriology laboratory, we will adjust the antibiotics and hopefully reduce the spectrum. Control the source. If we don't know the source, you can think at my big five, like in Safari. try to identify the big five. But here is, of course, the lungs and the abdomen and the urine, but also the skin. And sometimes, actually, the nurse is better than we are because he or she will look at the back of the patient and evaluate the skin perhaps more closely and identify some possible port of entry. And if the patient comes from another institution, think at catheters. Remove them. There is no way we should take any risk there. And in the emergency department, I'm sure it's the case in yours like in ours, sometimes say, yeah, the surgeon is, well, the anesthesiologist is, well, the surgeon says, why don't we do another CT scan? No. It's also a team approach. Let's go and control the source as soon as possible. If the patient is not so sick, if it's 4 o'clock in the morning, perhaps we can wait until 8 to have a well-rested surgeon. Okay. We need to personalize our therapies, and that will be a recurrent theme in this presentation. My former teacher, Dr. Weil, was telling us every patient is a VIP. Ventilate, infuse, pump. Ventilate, oxygen administration, yes indeed. Not to reach hyperoxia, of course, but to make sure that the PaO2 is in the normal range. Be careful with non-invasive support because the work of breathing can consume oxygen, as we learned. When should we perform endotracheal intubations? Big question. Well, we look at the patient at the bedside. I know. But how do you look at the patient? How do you teach it to the junior doctor? There is sometimes some evidence that earlier endotracheal intubation is better than later, but you cannot consider that all patients are the same. We need to individualize it. That's how we reacted in this paper to the Surviving Sepsis campaign guidelines. I'm very much in favor of Surviving Sepsis campaign guidelines, and we started this. The first ones were held in Brussels. And we believe that this is very important. But when I proposed our colleagues, I said, we need to write something on the right time of endotracheal intubation. My colleague said, Jean-Louis, there is no evidence, there is no prospective randomized controlled trial on this. The doctor at 3 o'clock in the morning must still know when to intubate the trachea, so let's give some advices. Let's try to personalize and say, okay, look at gas exchange, look at the patient, look at the PCO2 sometimes, look at the neurological status, look at the hemodynamic status. If shock is profound, you will need to intubate the trachea. So there are a number of elements to take into account, and I'll speak about it the day after tomorrow. Artificial intelligence will actually help us to identify the right time to intubate the trachea. If you don't know, you can ask the patient to pronounce metoprolol. Intubate the trachea. It's not mine, I found it on the internet, but I think it's really cute. I wrote this, no room for hyperoxia, as we heard and we will hear that hyperoxia is not good for the microcirculation. We and others have shown it. It alters, you must be kidding, alters the microcirculation. So let's go for infuse, very important. Every patient with septic shock will need some fluids, no exception. And you cannot go by formula because you don't know how much the patient may have lost. You don't know how much is going into the interstitium, and you don't know how much you will need to bring what we call a hyperkinetic state. A high cardiac output state is what you expect in sepsis. As when you and I have a flu, we know we have a high cardiac output. We are red, and we can feel our heart beating because we have a high cardiac output. So these discussions, more or less fluids, looking at survival, are of course doomed to fail. Because if you put the patient in the more IV fluids group, some patients may benefit and some patients may be harmed. And the other way around. If you restrict fluid, you could benefit some patients and harm some others. And we need to think at the fact that vasopressors have their problems as well. If we limit fluids but give more vasopressors, be careful. There is a risk of excessive vasoconstriction, which is very bad for the organs. So if you look at the recent literature, you will find this recent paper from the classic trial that created a lot of discussions. Restrictive, liberal, of course, no difference in outcome. Of course. You know, always look at mortality. I do this versus that, and I look at mortality. It's not the right approach. And we could get this one just 2 weeks ago, 3 weeks ago. The same thing, the Clovers trial. Again, very debated even before the end. There were complaints saying this is not the right thing to do. Of course, no difference in outcome. So does it mean that you can do whatever you like? Of course not. We need to personalize your therapy. So let me move on as time is very limited. This is another of these trials from Brazil this time. They wanted to have their big trial. And they gave fluids faster in the first hour or less fast in the first hour, and they look at mortality much later. Of course, there is no difference in mortality. Of course, ridiculous. But they just published 2 days ago this paper where they said, you know, with a Bayesian analysis, could we perhaps look at a subgroup of patients who could benefit from more or less fluids? And that was only 1/5 of the patients. In 4/5, impossible. But what would you say? Let's guess. So in which patient would it be a recommendation to give less fluids in the first hour? In which patients is it better to give more fluids? Oh, yeah, elderly patient with more poor myocardial function is better not to give too much fluid. Okay? Just the other way around. Just the other way around. 5% were better off with small fluid being administered in 1 hour. They were younger and they were less sick. Actually, perhaps they didn't need these fluids. Whereas in the other group, they were 78 years of age. With an Apache score of 17, 12% mortality, 12% needed renal replacement therapy, mortality close to 50%. That's real septic shock. Yes, indeed. So you see, don't try to guess. And be careful also about the terms hypervolemia or fluid overload. The surgeon who comes and says, oh, the patient is in fluid overload. There is edema here. Oh, you must limit fluid administration. No, maybe not. A patient with edema may be hypovolemic, especially if there is hypoalbuminemia, like in the cirrhotic patient with anasarca. So be careful about fluid balance. We need monitoring. And that's how we propose these 4 phases of salvage. Early stage in the emergency department, when the patient arrives, we just open the bottle. Optimization, now we need some optimization because we are no longer sure about what the patient needs. And then hopefully the stabilization before the de-escalation. Some people change the word de-escalation by de-resuscitation, but I don't want to de-resuscitate my patients. I want to keep them resuscitated. I don't regret my resuscitation, no. But de-escalation is the right term. Okay, so emergency department, we open the bottle, but very soon we can have some form of monitoring to individualize our therapy. And this cannot be based on a single variable, whatever that is. Blood pressure, heart rate, we cannot base this. We can base our approach on this. So we need to look, if possible, at a dynamic approach. Dynamic approach means if the patient is mechanically ventilated and deeply sedated, Then we could evaluate the effect of changes in intrathoracic pressure on the blood pressure curve. It's only in these circumstances when the patient is deeply sedated. It's a way to look at the Frank-Starling relationship. But as soon as possible, we should stop these sedative agents because they further compromise the hemodynamic status. So we continue with the fluid challenge. And indeed, of course, every emergency room doctor should be familiar with the use of echo. Not being an expert. No. It's not very complicated to look at the size of the chambers, and you could come to one of our courses in November each year, where we do the procedure in the ICU, and we transmit the images in a auditorium. So these things will never change, and the idea is practically that we give fluids over a relatively short period of time. Sadly enough, there are people who would like to evaluate the response over half an hour. Oh, give some fluids over half an hour, we will see. That's not a fluid challenge. You need to have a relatively short period to avoid giving too much fluid and avoid the interference with many other things that will complicate the approach. And that's how usually it is about 200 cc's in 5 to 10 minutes. Now, if the patient seems to respond, we repeat it. But at least we evaluate after a relatively short period of time. My time is limited now, but if you like, you can look at recent papers that show that this kind of approach is really the good one. Not too much fluid over a limited period of time. Now, in the ER, it may be like in the OR, where so many things happen, and you may not even have the 5-10 minutes to wait without touching the patient. So, yeah, we could even use shorter periods, maybe even 1 minute. You give fluids over 1 minute, and you evaluate the patient's response. But we need to individualize this response. All right? Should I look at blood pressure like in trauma? No. Because in sepsis, there is a fall in vascular tone, so that cardiac output may increase, which will be a sign of response, but blood pressure may not really change. So it's better to have an index of cardiac output response. And again, echo could be used. The VTI, it's not difficult to do it, and to have a stroke volume assessment. In the future, we'll have it automated, but I'll speak about it the day after tomorrow. All right, so if you like, you may say, okay, what about a passive leg raising test, an internal fluid challenge? I am not very good at doing it. I don't know if you are, you must test it. But when I do it, the patient has a stress response. Blood pressure goes up, heart rate goes up, simply because I changed the position of the bed. And of course, if you do it very, very slowly, it will work, but you will not see the effects of your internal fluid challenge. And you still need a good tool to evaluate the transient changes in stroke volume. Not blood pressure, stroke volume. If you like, you can listen to Xavier Monet. You can go on our website and look at the e-chat, and I chatted with him and said, how do you really do it practically? Okay. Yeah. Type of fluid. I hear some people saying saline solutions are bad. They are not bad. They include a lot of chloride. So there is a risk of hyperchloramia associated with a fall in pH. And any abnormality is associated with a worse outcome. So why would you induce hyperchloremia, which is bad for the kidneys. Now, are balanced fluids better? No, I didn't say that. I say it's a matter of amount. If you give only 1 glass, if you take only 1 glass of wine a day, I will say, okay, give me the size of this. Because and we wrote this several years ago, if people are good and measure chloride levels in their clinical trials, they will stop giving sodium chloride when the chloride levels go up. And if they are poor doctors, they will just continue until there is harm associated with hyperchloremia. And that's what you can find in clinical trials. When they gave too much saline, there was an adverse effect on the kidneys. We even wrote some ethical aspects. Do you really need to show that hyperchloremia is bad? But it doesn't, and they did it again in this trial, more adverse kidney events when there is hyperchloremia. Saline is not bad, but we need to check the chloride levels. And if the chloride levels tend to increase, or if there is severe metabolic acidosis, then we move to a balanced solution. Not Ringer's lactate if there is a brain problem. Don't forget that Ringer's lactate. Yeah, I will. Okay. Yeah, I don't know. I have no time to speak about vasopressors, but the Ringer's lactate solutions, the Hartmann solutions, are a bit hypotonic. Hartmann, who developed these solutions, was a pediatrician treating children with gastroenteritis who were dehydrated. So my last point, no dopamine. We showed that dopamine has no place in the management of shock of any kind, and septic shock in particular. And it's important for the ER doctor to realize that we should not leave a patient with profound hypotension. It's never good for a patient to have profound hypotension. That's what we showed here from a large database. Even 1 hour of profound hypotension is associated with a worse outcome. Others have shown that it could be associated with more renal dysfunction. So finally, the last point then, the target. Some people say, oh, it's 65 as a mean, huh? Do you agree 65 is a mean? No. Well, it's based on this French study. The target was 65 versus 80, and there was no difference in outcome. But again, the same scenario. There are some patients who are harmed, patients who benefit from each of the two groups. Now, the target was 65 to 70 versus 80 to 85, but in reality, it was 85 versus 75, okay? That happens, overshooting, that's okay. But it shows that it's already over 65. And in the group whose target was 75, there was more renal dysfunction in patients with previous hypertension. So 75 may not be sufficient. Okay, so let's bring to 75, 80, right? No. Look at the 65 study. 65 as a mean, or you could leave it lower in elderly patients older than 65. No difference in outcome. So I hope you are confused now, because you could say a mean arterial pressure of less than 65 is fine, mean arterial pressure. So I have the physiology remains, and I have no problem with our recommendation from the Surviving Sepsis campaign, except that people just delete in their mind the word initial. Initial mean arterial pressure of 65. In our previous guidelines, we added if initiated vasopressor dosing should be titrated to an endpoint reflecting perfusion. Individualized therapy, back to the same paper where we said we need to look at the patient, evaluate not only the past history, but look at urine output, skin perfusion, brain function. Let's, by the way, look at the diastolic blood pressure as well. And you can do a little noradrenaline challenge. Don't forget that if we recommend noradrenaline, it is because it has a little bit of an inotropic effect. The other vasopressors do not. So noradrenaline can still maintain cardiac output. And if it's not sufficient, we could add a little bit of dobutamine. But I see our moderator getting nervous. So I have many more things to say, but I'll stop here. Thank you very much.
Yep. Thank you so much. Now, I'm sorry, we are running a little bit over time, so I'm not going to take questions.
No, it's not
for this
10.
session.
It's not even 10.
But the good thing about this conference is that the speakers are here and in the bar. Not all the time. But conversations should and will continue after this. So sorry for running a bit short of time now. Just one thing, for those of you that haven't already registered, could you please just make sure you register at the front? That makes sure that you get your CPD and everything else. Ollie is going to take you to get some skis and give you some other things, but we will be back at 10:30 so that we can all get away to ski on time.
Yeah, skis outside. You have half an hour, 10:30. We still have 7 seats up here, so people don't.
the hotel for towels and mattresses. Is that organized? Have you done that? Or should Victoria do that? No, we haven't done it. There was no one. Yeah. So Victoria goes up for towels and mattresses for like six stations or something. And we will put a mannequin here and I think the tractor scanning station. So me and Victoria will start doing that and then we'll clear the room as we discussed yesterday.
know to where you're going, right? There's no method to the madness. So whatever this says goes, and just don't try to be like, yeah. Don't be too smart. Yeah, don't be too smart. You're allowed to be smart when you come to
map minus ICP. The map is diastole over systole. So we had scenarios with a meter pressure, and it was like.
Is this when I was with you?
I think so, yeah.
I know you crushed it though. Was it Dr. Al-Fault? You still need this out, or you good, brother?
No, I'm good, thank you. It looks like a minor. Very nice. Oh, okay, kein Problem. Ja, wollen Sie jetzt noch aufmachen? Okay. Kommt hier mit 12 noch mal zu. Ultrasound. Friday?
Yeah, or will we be here all day?
No, some go like to the heli base and stuff, but basically we'll see like the actual rock.
Okay, so we're going to have a walk around there and we'll still be doing TV bits skiing.
Yeah.
Just trying to figure out which is best to buy.
No, exactly. No, they just on top of the mountain. You know, the guy who's private.
Ski, yeah.
It's like next to the
Oh, is it?
And outside, there's not much. We're not here.
No.
Oh. There are more people here than that.
175. Kind of interesting. Right, so we're trying to just rank up some more. There's nothing to do about now. I think there's, some
25 a year, nothing.
I'm not sure. I think there's some like the. I think there's some of the small grab some live and stuff like that. That's not to me. It's not an issue right now. It's just that.
Hey, Rebecca. Come on, please take a seat. 1 minute to go, then we're back live online. We still have about 12 seats available up here. Just take a seat. It's only 90 minutes to go. Then you're free to the slope. Please come up front. We still have 10 seats available. All right, we still have 5 seats available up here. Please take a seat, ladies and gentlemen. We really need to push so you can get out of here at 12 o'clock. Oh, take a seat, please, so we can continue the program. So, couple things. First of all, about fondue. The poor cows, I'm telling you, please sign up. For people with a lactose intolerance or vegan or whatever it is, we'll organize alternative. Don't do the QR code if you're allergic to whatever or intolerant. Come to me. Come one of us with the air Zermatt thing and just let us know you want something alternative. Okay. The other thing is for the heli skiing, you don't need a guide. There's no point going off piste. If you go off piste, you're not gonna make it. Your seat will be available again from tomorrow on. So don't go off piste. Crevasses all over the place. We have the worst winter ever, snow-wise. So the helicopter is taking you on top of the ski slope. Then the other thing is, whoever doesn't want to go skiing or it's very interesting, there's an ultrasound workshop at 12:30. It's right in here. Ladies and gentlemen, they're truly the best. Like people who think they know it all with ultrasound, show up 12:30, they will teach you. And that's it.
Thank you. And I'd just ask you to remind your friends who are not here about the live stream, because it's a good way of being here and seeing some of what's going on or catching up with it afterwards for those of you that might not see everything. But anyway, welcome back. I hope you've managed to get your skis and little bits sorted out, so we're all good to go straight after this. Now, one of the things I find about these sort of conferences, I get to meet colleagues from all over the world. And in some ways it's really good. It makes me feel good about the job that I have and the things that I do. But sadly, more often than not, it just reminds me of all the great places around the world I wish I did work in. Because currently in London, it's grey, it's dark, it's wet. And our next speaker, Sara Crager, is from UCLA. And I'm thinking that's kind of slightly different where you work from where I work, at least in terms of weather, but probably in terms of resources and everything else as well. And just listening to one of the things that Ollie said about not going to peace, I think it comes into some of the things that we'll be talking about in this session, about guidelines, the way that we sort of formulate our decisions. This might be So our next speaker, Sara Crager, is from UCL. She's an emergency critical care physician working across the video and she's anyway, I'll pass you over.
Let's talk about ventilators. Oh, goodness. All right. Ventilators. I'll talk more quietly about ventilators, I guess. So, this, right here, there was a period in the winter of 2020 when I was getting some version of this text message from non-intensivist physicians from pretty much all over the world. Multiple times a day, desperately trying to manage their patients with COVID on the ventilator. Something like that, over and over and over again. I'll use this instead. Beautiful. Can you hear me on this? Beautiful. All right. Multiple times a day, physicians from around the world, I was getting a version of this text message. I called it my recurring COVID ventilator curbside. Now, these were all smart physicians. These weren't people who had no knowledge. These weren't people who do I heard of this ARDSNet protocol thing? These were smart people who knew basic vent management, were very well aware of protocols. They were all following this one or something like it. By this point in COVID, most hospitals had instituted some kind of protocol for the vent. That wasn't the problem. The problem was this. They would dutifully start following the protocol. And then they would keep going and get to the end, and the patient wasn't better. They'd done all the things. They'd done all the steps. They'd done them right even. The patient still wasn't better. They'd run out of things, which leaves you in a moment that feels like this. Now what? And that was everybody's question to me. That's the point that I got that frantic text message. Now what? Now, what the answer is, most of the time when I'd have this conversation with people, new and improved algorithm. Maybe we need a different one. Maybe that one wasn't good enough. Maybe it needs to be more complicated, maybe less. But I actually don't think that the answer to now what is a new and improved algorithm. I actually think that we need to take a step back and re-examine the bigger picture here and question some of the basic premises we're basing this off in the first place. And so let's take a moment to do that. Because our vent management priorities across the board, whether we're talking about research or education or QI hospital protocols, when we're talking about vent management priorities, they all start and end with algorithms. Now, before COVID, I hadn't really thought about this that much. I hadn't really conceived it that way. But after 2+ years of having that where the sidewalk ends moment again and again, and knowing that it wasn't just me, that I was getting people from all over the world having the same moment over and over again, I started questioning whether it was actually the right thing. The premise that all good vent management should start and end with protocols, maybe, but maybe not. I think that we need to acknowledge that as humans, we like algorithms, but for a psychological reason. This is one of my favorite quotes in the entire medical literature. It's from an editorial from two of my favorite people in all of medicine, Dave Schreiger and Steve Green. The illusory sense of psychological order provided by a seemingly precise tool. Now, in this editorial, they're talking about GCS, which we're obviously not talking about right now. But I found this concept applies to so many different things. Algorithms are psychologically reassuring to us. They give us this sense of order. There's arrows on a page. You follow the arrows when you don't know what to do. It's fantastic. And the sort of artificial order imposed by algorithms is especially appealing to us in times of uncertainty, like, say, COVID, for example. We all remember that feeling being like, I want an attending to ask, who knows about this? That would be nice. An algorithm is beautiful at that moment. I think we also tend to feel particularly sort of virtuous following an algorithm, when doing so is something that we can be like, I am following evidence-based medicine. And so I think we need to talk about, for a moment, evidence-based medicine. If we're going to talk about what it might mean and what it might look like, to move forward maybe beyond algorithms a little bit, let's talk about critical appraisal of evidence-based medicine, and not just like, was this a good study, let's critically appraise this study, but big picture, how we think about evidence-based medicine in critical care. Because the thing is that the fundamental structure of the vast majority of studies revolves around the idea of, I'm going to take thing A, compare it to thing B, declare a winner. Say thing A is either better or worse than thing B. I think more often than not, especially in critical care, that's the wrong question. I think something closer to the right question that we should be asking is, in fact, what is the right tool? Because if I start trying to use a hammer to screw in a screw, I'm going to conclude that hammers suck and screwdrivers are awesome. And so to figure out what the best tool is, you have to know what you're using it for. And that kind of subtlety, it's not that we don't know it exists, it's that it's hard to do that in a randomized controlled trial. The other thing is, you can have the best tools in all the world, but if you're not good at using them, it doesn't matter. As I rediscover every time I try and touch something that comes from IKEA, just because you have the right tools, you theoretically know how to use them, doesn't mean you're doing a good job. And the more complicated an intervention is, the more operator dependent it gets, the more important this is. So for example, a great use of evidence-based medicine was the studies of steroids in COVID. That was a single intervention. It wasn't operator dependent. Me giving the patient steroids is no different than the nurse or the medical student or anybody else. Great, fantastic. Vent management in COVID, that is highly operator dependent. Not all people are equally good at this. Now, another piece of this is what I call Murphy's Law of Critical Care, which goes something like this. The more things that have gone wrong, the more things that will go wrong. And here's the thing about critically ill patients. The development of every new thing, every new complication of what we do, every new problem they develop, every new secondary thing of their primary problem, each one of those things, it doesn't make the patient linearly more complicated. It's more like almost exponentially more complicated, because every new thing interacts with every other new thing and creates its own problems, and then also limits our degrees of freedom in terms of management. These patients get complicated. This is not like a patient who just has hypertension and what's the best drug. Your critically ill patient, they're a snowflake. And the sicker they are, the more snowflakey they are. So for all these reasons, I think we need to question our premises about algorithms and about the evidence-based medicine we use to get them there. I don't think that algorithms, better ones, different ones, more complicated ones, are necessarily the answer here. I think we run up against this. The yes, everything should be as simple as possible, but no simpler. And oversimplifying something can be just as worse or even worse as the other way. And this is where I think we've arrived with algorithms and ventilators. And we may have already been there for a long time. We just didn't notice on a large scale until COVID. So what's the alternative? If not this, I mean, I can't sit here and complain about something and not propose a plan B, right? So if not this, what? I think that we instead need to start trying to move towards an expertise-driven approach. Now that sounds lovely, I'm sure. What on earth do I mean by that? Like, it sounds good and inspirational, and we can take a screenshot and post it on Twitter if I remembered how to log into my account, which I don't, but now it sounds good. But it's one of those things, it sounds good, but like, what does it actually mean? Because I think most people, they see this and they're like, yeah, and then they're like, but actually what? Like, do I just like hope I'm smart today and it's a good brain day? No, that's not a good way to do medicine. What I actually mean by this is I think we should be replacing algorithms with an organized clinical problem-solving approach. That is my answer to the algorithms. But before we talk about in detail what that means for ventilator management, let's take a moment and clarify some terminology here. Because in order to make a proper argument for anything, you gotta start by defining your terms. And I think this has been a particular problem in a lot of the vent studies. So we're gonna define 3 categories of terms and frame the rest of our discussion that way. 1, problems. 2, targets. And 3, strategies. And why do I think this is so important? Well, for example, I'm breaking things down like this because if you go back and look at, say, the ARDSNet trials on low PEEP, high PEEP, it was really interesting. From one perspective, the trials were a mess, right? Some were like, yeah, high PEEP wins. Others were like, ooh, high PEEP's bad. Why? What was going on here? Well, I think a lot of what was going on with those trials is that we were inappropriately treating PEEP as a target rather than a strategy, when all along, driving pressure is probably the target and PEEP is in reality a strategy. So let's explore for a moment what these terms mean. Problems. This one is simple, kind of. Your problems are whatever it is that's wrong with your patient that's making them sick that you need to fix. Now, it's a little more complicated than that because it turns out that often framing the right question is the hardest part. And I see a lot of patients who have a lot of harm done to them, not because we didn't have the right answer, but it's because it was to the wrong question. And this is particularly problematic in respiratory patients because of what I like to call the respiratory failure masquerade. Because all kinds of sick patients come in looking like they're in respiratory failure. Your DKA patient, they don't come in and say, hello, I have a metabolic acidosis. They come in and say, I can't breathe. Your patient in shock. They often don't come in and say, hello, I'm in shock and hypoperfusing my tissues. They say, I can't breathe. And they look like they can't breathe. They're dyspneic. And we are humans. We're simple creatures. We're like, patient says they can't breathe. They look like they can't breathe. Ta-da! It must be a respiratory problem. So, ask the right question, define the right problem. That is the thing we need to fix. Next, targets. How do you know you're fixing the problem? You know, unfortunately, ICU patient management, as much as it would be nice, isn't instant gratification. It takes time for them to get better, and often there's a little sine wave. They'll get a little worse, a little better. So how do you know along the way you're doing the right thing? How do you know 10 minutes from now, not 3 days from now, you're making your patient better? And what's hard about this is often the targets aren't obvious. And some of the obvious targets are actually the wrong things. And this is where I believe there's a critical role for evidence-based medicine. Because it simply isn't clear. It seems like, oxygen, that seems like an obvious one, but maybe driving pressure is better. But we never would have come up with that without evidence-based medicine. But there are pitfalls to be aware of. So there's this one, magic numbers. We really want a magic number. We want one perfect magic number with a nice strong cutoff that tells us yes or no, whether my patient has this, whether they do well on this therapy. They don't exist. I'm sorry, that would be nice. Pitfall number one. Pitfall number two, pitfall in everything from medicine to beyond. Make important, measure what is important, don't make important what you can measure. See, even I can't get it right. So, for example, why are we so obsessed with blood pressure in shock instead of perfusion? Well, because we can measure blood pressure, but not perfusion. That's why. Now, this goes along with pitfall number three, which is making the numbers pretty does not necessarily make the patient better. So the classic example of this is the resident who proposes that we give a beta blocker for sinus tachycardia. Why? Their attending is going to come in and see the sinus tachycardia and yell at them. So we could give a beta blocker. It would make the numbers pretty. It would make the patient worse. That is not helping. So a target where you make the number pretty but made the patient worse, big pitfall. Lastly, strategies. This is when we really get to the hard part. This is, once you know what your target is, how do you go about actually getting there? How do you actually fix the problem? What do you actually do? And this is where big picture, whether we're talking about ventilators or shock or sepsis, I think our organized clinical problem-solving approach comes in. And I really like to focus my approach, again, across the board, not just with ventilators. I like to focus my strategy here around what I call iterative hypothesis testing. Because I think it's a lot of time in medicine easy to be like, I'm going to do this and it's the right answer, or that was the wrong answer. It's a process, right? This isn't a yes-no question. This isn't a, I know the sure diagnosis right now. This is a process we are going through with our critically ill patient. And it goes something like this. First, we're going to gather some data. Once we gather our data, we're going to revise our hypothesis, form our hypothesis, and based on that, we're going to adjust management. Then we'll gather some data based on that, further revise our hypothesis, rinse and repeat, and voila, iterative hypothesis testing. And this is the process that I go through. Now, by now, you're probably like, can you just get to the vent part? So that is problems, targets, and strategies. Now let's talk about applying this organized problem-solving approach to actual ventilators, which is what you came to hear about in the first place. So we're going to go through one by one, and let's start with problems. So here's the thing about all the problems. It seems obvious that the lungs are the problem, right? Unfortunately, the lungs do not exist in a vacuum. And the lungs, and then what you're doing with the ventilator, have huge effects on all the other organ systems. So you need to think about your vent management not just in how it affects the lungs, but what it's doing to everything else. And the way I organize this in my head is as follows. I break each of these down into 5 categories. And the 5 categories of surrounding things that the vent needs to listen to are as follows. 1, obviously the pulmonary problems. This is the clear one. Nobody's going to forget that the vent has something to do with the lungs. These are all of the different things that can go wrong with the lungs. Their compliance is poor, their resistance is high, they have a pneumothorax, they're de-recruited. That would be a whole 3-day lecture all by itself. That's the obvious one. But there's more. The next most obvious one is that the lungs have to live somewhere, and they live in the thorax. And all kinds of things, like if somebody's morbidly obese, their chest wall, if they have abdominal compartments under their abdomen, like to mash down on the lungs. So they have to live in the thorax. But now things get a little more complicated because we have some hemodynamic problems as well. Because positive pressure ventilation has profound hemodynamic effects, and we cannot forget that. Now, depending whether you are bleeding to death and having septic shock at the same time, or if you're in, well, we're not going to call it volume overload, if you have too much intravascular volume and are in heart failure, it can be a good thing or a bad thing, but you have to take it into account in both directions. Metabolic, this is a big one. Your body's set up so that breathing compensates for a metabolic acidosis. Just because we intubate the patient doesn't mean you can stop doing that. We just need to do it for them. So if I have a patient who's massively bleeding to death, their Bath excess is -25, they're in DKA and for some horrible reason I just intubated it, or whatever it is, they just coded, if I know they have a metabolic acidosis, compensate for them. You gotta take that into account with your vent settings, whether or not there's anything wrong with the lungs. Now let's move on to neurologic. This is not as obvious, but the thing to remember about this is that in patients with neuro injury, we have to baby them along. Why? Because the injured brain has trouble with autoregulation. Now, the brain's very picky about things like that, and normally it goes about the business of maintaining very narrow and specific parameters until it's injured, until there's TBI, elevated ICP, a massive brain bleed, say, at which point it can no longer do that. So we then have to be much more meticulous about maintaining the O2 and the CO2 in places the brain is happy. Has nothing to do with the lungs directly, but is important because, as we said, the lungs live inside the patient, so does the brain. Now let's talk about targets. So this is the key thing to remember when we're thinking about targets. Ventilators are to lungs like ankles are to crutches. Not like infections are to antibiotics. The ventilators are not fixing your lungs. All you are doing with the ventilator is you're letting them limp along until they can get better. So the idea here is not to push the lungs as hard as you can and wring the best numbers you can get out of them. It's like, if you're on crutches and you hurt your ankle, what you don't want to do? Try and get your very fastest time on your 5K, right? That doesn't make any sense. You want to use your crutches to limp around. It's not going to be pretty. It's not going to look good. Buy yourself time with your crutches to heal. That's what the lungs, when they're injured, are like. And so as a consequence of that, when I'm thinking about the ABGs I'm trying to get, you don't want the prettiest EBG you can make. That's not the right way to think about it. Because that's like trying to run as fast as you can on your broken ankle. What you want is to say, okay, what's the worst looking ABG I'll accept because I'm letting my lungs limp along. Now we also know in terms of targets that this problem with making the numbers pretty is not making the patient better. This has special significance in the world of lungs because many of the biggest mistakes we've made historically in medicine have been with lungs and pretty numbers. We thought that 100% oxygen was awesome. Turns out not so much. That actually made things worse. We thought that like tidal volumes of 12 cc's per kilo, yeah, it made the oxygen better. Yeah, it seemed like it made the tidal volumes better. No, it made the lungs worse. So we have to be very, very careful to understand too pretty may actually be a bad thing. Now, when we're talking about targets, we have several different categories. Oxygen. This is the obvious category, right? It's on the monitor, everybody freaks out if it's low, somehow nobody freaks out if it's high, but we'll keep working on that. But clearly, over and over again, in critical care, we're learning that too much of a good thing is probably too much of a good thing. Hyperoxia is bad. This is not news. But the question that I found myself, and you guys probably found yourselves, repeatedly having to answer during COVID was, how low is too low? Because like, oh, don't look at the number, look at the patient, but like, 76, is that too low? Is 86 too low? Sometimes I felt like I was playing chicken with my patient's oxygen saturation because the patient's like texting and eating flaming hot Cheetos, and I'm like, you're setting 77. How low is actually too low? To me, the central question here with targeting and oxygen is actually the difference between hypoxemia and tissue hypoxia. Because as it turns out, when somebody was showing slides this morning of you're hanging out on Everest, you have to be actually quite profoundly hypoxemic. Your SpO2 has to be very low before you actually have tissue hypoxia. So the question is, if I have a patient whose hemoglobin is 15, they're totally healthy, their cardiac output is fantastic, they're not under a lot of physiologic stress, so they don't have a demand, is it a problem if my SAT is 80? Is it a problem if it's 75? Because that's right about when we start getting into trouble. Is hypoxemia, is my O2 SAT intrinsically being low without causing tissue hypoxia, is that a problem? And maybe it might be, for example, with a patient with pulmonary hypertension. So this to me is the central question, and we don't actually know what the right answer to this is yet, so I wish I could give you, this is a hard and fast oxygen you should be targeting, but I cannot, I apologize. CO2 is a little bit easier. CO2 is all about the clinical context. So this is usually the thing you sacrifice, right? I don't care that much if the CO2 is high, especially if they're asthma COPD. Really, at the end of the day, it's the pH that matters. And the main reason I care about the CO2 is the pH. Now, can I please give you a hard and fast cutoff for the right pH and the wrong pH? This is the best I can do. 7.2 something. 7.25 is nice, but it kind of also depends on the context. If I have an asthmatic who codes from breath stacking every time I go above a respiratory rate of 8, I can live with the CO2 that's high, and I can probably live with the pH that's closer to the 7.20 or maybe even less for a little while. If I have a pulmonary hypertension patient, a patient with bad neuro injury, or a patient in profound shock on multiple pressors, not so much, so it depends. Next, lung protection. So this is a whole lecture in itself, and I am almost out of time, so we are not going to do that entire lecture now, other than to say that we've tried multiple variables, multiple markers, multiple targets to tell us that what I'm doing on my vent is making the lungs not better. Because you know what you don't do with crutches? Thwack your ankle with them over and over again. That doesn't help. And that's often what we're doing with the ventilator. Doesn't help. We've tried all these things. Tidal volume, plateau pressure, static compliance. It's actually probably the driving pressure from our current literature that is maybe the best target, or at least that you can feasibly do, most people who can feasibly do on a ventilator you have in front of you. But I actually have gotten increasingly obsessive about work of breathing and accessory muscle use. Because during COVID, and in both intubated and extubated patients, that has become a huge target for me. That if what I'm doing decreases their work of breathing, I think I did a good thing. Now, I don't have a bunch of evidence for that, because this is hard to measure, but for me, that's become important. Now, finally, strategies. We're gonna go through this very fast after we talk about mental status. The only question here, when we're talking about targets, is, do I need an awake patient? Are we trying to get neuro exams 2Q hours to know if we're going to the OR? Does this patient need to maybe participate in a goals of care conversation, like, are we gonna trach them? How badly do I need this patient to be awake? Is it okay if they're deeply sedated and completely paralyzed, or is that a huge problem? What's my priority here? Lastly, strategies. This is how we accomplish all of the targets that we just talked about doing. This is where the expertise comes in. Because as you may have noticed, we can't achieve all of those targets at the same time. It's one of those you can't have everything you want at the same time. So part of your job here, part of your job as an expert, is to prioritize, to understand you can't make everything perfect at the same time, figure out what you're going to prioritize and what you're going to sacrifice. So, what are a handful of our key strategies for the vent? PEEP is one of them. There's all kinds of things you can do with PEEP. PEEPed optimization, it's an art. It's a complicated art. The core idea of this art is to prevent atelectic trauma while avoiding overdistension, in summary. But actually doing it, that requires expertise and patience. Minute ventilation. This one's an easy one. What you really want is like, okay, what's my target pH and CO2? And that's kind of how I'm going to get there. Fantastic. You know, usually, I feel like we have more degrees of freedom with the respiratory rate, so I set my minute ventilation where I want, and then I figure out what my respiratory rate needs, unless I'm asthma COPD. Then, next, once I've set my respiratory rate, I can talk about IDE ratio. You have options here. Do I need to make it really long for COPD? Or should I do inverse ratio, or maybe even APRV if I can't oxygenate? VQ matching, we forget this a lot. Keep in mind, you can be having the vent do all this amazing work. You can optimize the mechanics, everything is beautiful. If your physiologic dead space fraction is 50%, you're wasting all that lovely ventilation the lungs are doing. You're getting yourself nowhere. Don't forget about this. Don't torture your lungs and wring out every ounce of tidal volume you can get if you have a huge physiologic dead space fraction. And finally, synchrony. And all I can say to you about synchrony is that doesn't always require this. Massively, massively overdosing your patient on sedation isn't always the answer. Sometimes the answer is know how to adjust a ventilator to make it more comfortable for the patient. At the same time, I would say, since I've become so obsessed with work of breathing, what you also don't want to do is let them sit there, despite all your adjustments, and work super hard and injure their lungs because of it. So don't be afraid to sedate and paralyze, just know how to not do it. So that is precision vent management. I'm hoping that this approach doesn't give you a clear answer, but at least maybe helps you think about what to do at that moment when you're like, now what? An organized clinical problem-solving approach. These are the key components. Thanks for listening.
Hello. That was brilliant. Thank you very much. Don't leave the stage yet. Any questions from the audience? Well, whilst we set up the next speaker, sorry, a bit of interference. Whilst we set up the next speaker, I've got one question for you. So we had Jean-Pierre on earlier, the ex-president of seemingly the universe of ICU. If we get him drunk later on tonight and we swipe his computer and you can send some emails to change the world of ICU tomorrow, what 3 things would you say, other than saying, you know, don't listen to Jean-Pierre, listen to Sara, she knows what she's talking about?
I mean, he actually said most of them in the talk he just gave, because if I could convince everybody there's nothing magic about the number 30 cc's per kilo, we shouldn't just give it to everybody who meets his criteria, that would be lovely. I would just steal his presentation and send it out to everybody in the world. And just because somebody has a high lactate doesn't mean they have sepsis. That would be the second one, and I just repeat those 2 over and over again, probably.
Fantastic. Thank you very, very much. There'll be lots of time to continue these conversations on the slopes and in the bar, but thank you. That was fantastic. So I have another challenge in pronouncing your name, but I've been practicing this one. So Domagoj Damjanovic, this is the second time of introducing him, I have to say, over the years. He's a cardiothoracic and intensive care physician, originally trained as an anaesthetist. He works at the University Hospital in Freiburg and has an interest in ECMO and resuscitation. And today we're going to talk about using the ultrasound to help you with resuscitation, but I'll let you hear from him.
Thanks, everyone. Thanks for having me again. It's so wonderful and really, really awesome atmosphere. And thanks also to Professor Vincent and Sara, just, you know, making this happen and helping create this atmosphere. Absolutely beautiful talks. And these talks were so much into physiology and so much into special knowledge and cutting edge intensive care that I think we need a little break here. And we need a little holiday. We're getting back to pretty much simple things, and you got me with these quotes, actually. Thanks for that. We're going to talk a bit about training for the use of the tools we have in intensive care, especially in cardiopulmonary resuscitation. These are my confessions of interest. I'm an anesthetist by training and working for cardiac surgeons. I'll leave it to your discretion again whether this constitutes a conflict. My institution has received some ultrasound machines on land for ultrasound courses, and I'm also an instructor in ultrasound courses, and of course, I'm an ultrasound enthusiast. I have put the show notes here in the references so you don't get stressed out by taking the photos of the authors and studies and stuff. So you will find everything in the show notes. I'll display this in the end. So let's go on a little holiday again, very much like last year, to my home country, which is Croatia. And last year we were talking about there's two bridges there, Maslenica Bridge, and now we're moving to the seaside to Zadar, which is the really beautiful little town at the coast, at the beautiful Adriatic Sea. And I invite you to close your eyes a bit and let that sound sink in. That is called the Zadar Sea organ. And this is how it is made. You don't need to get too much into details. There are some pipes mounted in the pavement, actually below the pavement, below these steps, and they are below the water level, and the movement of the waves creates the sounds. And those are connected to horizontal organ pipes that make the sound. It comes out of the pavement. But actually, back here, the learning points about ultrasound in cardiopulmonary resuscitation will be a window in the breast, ultrasound, and the advanced life support algorithm. A way out, training, process optimization, and my pet peeve, simulation. So why is it that most of you would not want to miss ultrasound in CPR? I guess because it gives us additional insights. I think you cannot argue about that. And I give you a pretty simple example. Like, what do we know, what can we know about what is going on inside the patient during cardiac arrest? Actually, we know something about the electric activity using the ECG. Systemic perfusion is harder. Actually, we can look at the patient, we can have a look at that pale, grayish skin and say that one is not perfused. We can have end-tidal CO2, and if there are art lines in, we can get an idea of the systemic perfusion that whatever happens inside the body is able to generate, or what we are able to generate with our chest compressions. And what ultrasound adds is clearly something unique. So unless you have the art lines in, which is clearly not the case, let's say, in the pre-hospital setting, and in most of the cases, I must say, you don't have any idea of the cardiac activity that is behind that rhythm. Of course, in fibrillation, it's clear. In asystole, sometimes not so clear. Maybe we'll come back to that later in the role of ultrasound. But mainly, talking about mechanical activity of the heart itself, only ultrasound can give you this information. These are some examples. The image quality is as good as it sometimes gets in CPR. Here you see a heart that is moving or not. Here you see the ECG down there. It is running. That means that is organized activity, but no movement at the myocardium whatsoever. Electromechanical dissociation, and in the current guidelines, the term is called PEA, pulseless electrical activity. Now moving further, this is a heart that moves, and if you concentrate on the aortic valve there, it opens. That tells you that whatever the systemic perfusion is, this heart is doing something. And you might get an idea of what you can do to enhance this. Maybe you would want to treat this arrest rather like some kind of profound shock than myocardial standstill at all. Maybe this heart does not need 1,000 micrograms of adrenaline. Maybe it needs less. Maybe it needs continuous infusion, and so on and so on. So it gives you really deep insight. You can even observe what happens in the chest while you are performing CPR. Well, the colleagues from my department are actually more straightforward. I remind you, it's cardiac surgeons. And when the anesthesiologist says, I'd like to look inside the body, the cardiac surgeon goes like, yeah, use the retractor, open the chest, and you can see the heart. So let us do a show of hands. How many of you have ever observed a heart during open heart surgery, looked inside the chest, and seen how it fibrillates, how it dilates, how it is stopped and restarted again? Isn't this fascinating? Yeah, thanks. So many. Do you remember those moments? Do you remember this aha, like, wow, I'm so excited about that? Well, at the first time, so now I'm not more excited so much. But, you know, this is a view inside the body, and it tells you a lot. When you are on the anesthesiology side doing TEE and stuff, and you are trying to get off the bypass, and it's all about like, do we need more fluids or less? Do we reduce the bypass? The anesthesiologist's view is one with the ultrasound, and the cardiac surgeon has their hands on the heart, and they can tell you, yeah, give some more volume, congest a little bit more, give load or less load. So it's hands in the chest. Now, on the C organ, you can't look inside it. You can't look inside the corridor, and you can't see the pipes from the outside. To the right there, you have some little windows, but you can't see anything. It's dark inside. It's a service corridor. The holes on the left, these are where the sound comes out of the installation. And I think we have such an instrument in medicine that is very often compared to ultrasound. And this is the stethoscope. And maybe you have noticed, or you have read, that this is actually not quite a precise name, because scopein means look, and it should be called a stetophone, because you are listening to sounds. Now, of course, what ultrasound, and that one is borrowed, by the way, from the POCUS Manifesto from Larry Israel. If you haven't read it, do it. We are placing a window in the breast. And what it tells us is, we saw it, we have mechanical myocardial activity. I went like, let's go with the extremes. Does it work hard or doesn't it work at all? We can look for reversible causes. We can, let's say, see right ventricular dilation, and during earlier times, this almost always was equal with drawing up the thrombolytics. Then we are, of course, talking about the evergreen, the pericardial effusion that you can detect with ultrasound easily and drain and save a patient's life. Not so often do we talk about other things than echocardiography. That is, POCUS pulse checks, something that has emerged during the last 2 years, especially lung ultrasound during CPR or during the pauses, the great vessels, and so on. And when it comes to procedural guidance, of course, it is helpful to see what your instruments are doing inside the body, like needles, small needles, or big ones for eCPR in our place, or the wires you are trying to get up there in the cannulas, and also confirmation of ET tube delivery in airway management as a fallback option for ETCO2. And you can, of course, integrate that into your code very easily. Here's an example. That's airway ultrasound. Did you see it? I mean, you don't need to get the sonographic picture. You need to get that it's quite quick, and you can do it with the A. Totally easy. And the true value of ultrasound has, of course, been recognized by the market. This is eBay, and they say this is a Siemens resuscitation device at pretty low cost, I must say. Good price. So no wonder that all of you resuscitationists consider ultrasound as a game changer, and you wouldn't want to miss it. But guess what? There's bad news, and that made me sad. And this has been going on for the last few years. And I was always like trying to look aside and close the eyes a little bit and ignore all that sobering information. And I need to introduce a new tool to you. And that's the new tool. It's the UPS. And the UPS has something to do, I called it dimensionless ultrasound enthusiasm. And that really much increased with the advent of protocols integrating ultrasound into resuscitation algorithms. And those protocols really took care of that issue. They were published, they evaluated these things way back 15 years ago. And then there was even a publication by the resuscitation guidelines incorporating ultrasound into the universal advanced life support algorithm, which means, yeah, we were really, really happy about that. That was the plateau, the climax, and then some things happened and things went down. So this is actually the ultrasound pain scale, I must say. Let's go through this, the FEEL algorithm way back in 2007 and 10, and then the integration in the universal ILCOR algorithm. Everyone was happy about that. Then 3 publications in a row showing that the use of ultrasound leads to a prolongation of interruption in chest compressions. 3 in a row, actually, during 2 years. Then there was a little more enthusiasm with some protocols emerging, again saying, if you do the right thing, things get better. And there was the advent of TEE in cardiopulmonary resuscitation, giving us new information on ultrasound in CPR. And that was really a nice thing. That may be a way forward, but surely not everywhere, simply because of accessibility. And then, worst times ahead in 2020 and 2022, there were 2 systematic reviews by Josh Reynolds and co-workers, and they were dealing with the role of ultrasound in prognostication. That means if you see a mechanical standstill of the heart, what does that mean for the prognosis of your patient? And would you use that to terminate resuscitation efforts? The review clearly says no, and the guidelines clearly say no. And then 2022, a very sad year for ultrasound. Okay. They said, detecting reversible causes, the diagnostic utility of point-of-care ultrasound is not as good as we think and as we celebrate. It's in fact not so good. And in the end, there is even some harm, some signal of harm, and that is the prolongation of pauses in chest compressions. And then when the ILCOR said yay, now they say nay. This is just a summary picture of the studies I was talking about. I'll put this in the show notes as well, so you don't need to follow there. Okay, it all comes down to those pauses, over 10 seconds and even more. We also learned that in almost all codes, depending on the point of time where you scan, the right ventricle dilates. So by no means does a dilated right ventricle after CPR equal pulmonary embolism and the need for thrombolytics. The prognostic of value of standstill is low and also time dependent. It very much depends when into the code you do the scan. Something nice where ultrasound actually challenges the guidelines, so the other way around, is the information that when you compress in the midline, what the guidelines tell you, there is sometimes not the right compression point. It might be somewhere else, and you might improve your chest compressions by that. So there is really a challenge between ultrasound and the guidelines. This is, we suggest against the routine use. So that's the proof, you can read it in the guidelines. So we need to switch to preventing further damage, rather than celebrating everything that this superpower can do for us. And we need to, take care of the very basic things that are important to every code. That is why I'm wearing a t-shirt of a famous Kids Save Lives campaign in the federal country where I live. It's Löwen retten Leben, so lions save lives, a school program that is very effective and very beautiful. Reminds me of the importance of basic life support and the basics done right. There is, of course, potential for distraction in ultrasound. Some call it the PANTS syndrome, which is actually physician acute new toy syndrome. But this is not only down to ultrasound. If you are honest, this is down to many tools that we use in CPR, and we have already for many years been struggling to integrate these into the codes properly without disturbing the code. And I'd like a show of hands again once you see the next clip, and tell me if you have been there ever. Is this an AV dissociation? This is your ECG in the code. And once someone says this, is this an AV dissociation? Everyone goes like this. And no one goes like this anymore. So tell me, have you been there? Yes, heads nodding. Okay, of course, this also happens in ultrasound. This is borrowed from ultrasoundpodcast.com, the famous one, that's Matt Dawson. Okay, and please get back to what is actually your answer for that. How do you make your folks not be distracted by the ECG? You have your strategies, right? You tell them stop, start. You tell them only one looks at the ECG and others are doing their jobs. So actually training is the solution. And that's where I want to get in the remaining minutes. So we want to reconcile the worlds of ultrasound and ALS again by means of training. Only we must consider that we are looking from different planets. The ultrasound training folks are talking about image acquisition, image interpretation and integration, but most of the time it's about getting that image nice, a nice view of the ventricle, not foreshortened and everything. And after that, we talk about interpretation. While the ALS folks have a lot more other stuff to do, and ultrasound is only one little part of it. So we need to make these worlds meet. And this can maybe work if we switch from a single task training, the things we will do in the ultrasound workshop later, getting the hard axis right and all those positions and stuff, to a more process-oriented training. How can this work? We need to have awareness of those news. We need to be aware of the problems. You need to update your teaching content and adapt your learning objectives. And when you practice cardiac views, use probe on and off, use 10-second sequences and record your clips. This has been evaluated way before, 15 years ago, and we still try to update these things to make these resources available. And here's a little example how that can work. Chest compressions are ongoing, respiratory checks. Yeah, they are really doing it. And now it is announced to the team that they will perform ultrasound. They use a little internal medicine portion of gel. They place the probe under ongoing chest compressions. They do a countdown, and they record a clip. They resume chest compressions, and only then do they review the clip. So that's the way to go. And still, the most important protocol, the most important point of the whole clip, of the whole procedure, is RCC, that is, resume chest compressions. How you can get there, we will show you later. We have basically integrated simulation for ultrasound into simulation of ALS scenarios. There is also a simulator been released by some Canadian folks. It's all in the show notes where you can find and download it. And it's totally easy technology, so I will skip that video, how it works. That brings you to the point that you really integrate ultrasound into your resuscitation training. And you train all codes, including the hands-off times and everything. We have published this, and it has been evaluated in simulation studies, in real-world studies, and the good news is it works, it shortens pauses. And this is, I think, how we can get better and go for recovery of the ultrasound enthusiasm. Some questions to discuss is when and where and who can be an instructor for this. And my summary is the idea to integrate ultrasound seamlessly into the ALS is not new, but there is a lot of room for improvement and training and simulation, I promise, in targets. So train, simulate, resume chest compressions so that you can relax, get the sound that maybe helped you save a life, and have this heart beautifully beating to sounds and waves. Using a symphony, an orchestra, with the correct timing. I'll take your questions. Thank you.
Thank you so much. That was fantastic. Questions from the audience? I see any hands? Well, in that case, I get to ask my question. I like this bit. So I'm a big fan of TOE. I'm rubbish at doing it, but I'm still a big fan of it. What's your experience of using it in cardiac arrest? And presumably you have to pause to place the probe in the first place, but can you keep it can you use live sort of real-time intra-compression views?
Yeah.
So with transesophageal echo.
I didn't get your question. I'm sorry.
With TOE, with
yeah.
transesophageal echo, what's your experience of using it in cardiac arrest, and can it be safely put down during compressions?
Yeah, of course you need an intubated patient. That is the safety point, but once they are intubated, it's easily. You can pause the compressions for actually getting it down, but then you can keep it safely there, and you can get your views easily. And it opens up a whole new world of seeing what is going on within that patient without the safety concerns of interrupting compressions.
Cool. Any questions from anyone? Where's our roving mic gone? He's coming. Just keep your hand up so you can see where to bring it to.
Hi, thanks for a really interesting lecture. How do you feel about we were just discussing the sort of targets and goals and all that in the previous lecture. Do you want to use the ultrasound for each and every cardiac arrest? I mean, how do you feel about using it in a VF arrest? Will you go straight for the ultrasound or try and just go ahead with the protocol?
This is, of course, a trap question, isn't it? No, of course, we will go for the basics first. That was actually my message. And basics is not only chest compressions, it's defibrillation, it's accounting for the airway, whatever you want to do to secure or not to secure. But these are the things to be done first. If they are in VFib the first minutes, you get the defibrillator, right? Once they are in VFib for 20 minutes, 30 minutes, it is really worth looking in there to still find a reason or to see how they dilate. If you ever watched a ventricle dilate under VFib, and not moving anymore. Simply, they cannot get back to their original shape. And these are the things that we learned from the OR, from the heart OR. So yes, in every code, once in a while, but first do the basics right.
Hello? Yeah, brilliant. Thank you very much. And the other advantage of esophageal echo is helps you place ECMO, my other pet enjoyment. Right, thank you so very much. So again, reflecting the international nature of our conference, our next speaker started in France and then moved to Geneva and then was still responsible for setting up FOMED in France. So Alex Jeleff is an emergency and intensive care consultant, and he's also working in the operating room at the moment, helping him sort of continue his research. And he's going to talk to us today about ventilation after RSI.
Maybe waiting for the curarization, we will see that. Thanks for the intro. I'm very happy to be here, a little stressed too, because I'm a French guy, and as we know, we are the best in foreign languages. So, let's go. I have not disclosed, because I'm a field physician, as you can see, my presentation will be very practical. When TBS asked me to present on the ventilation topic, I realized that ventilation is not always the focus in the management of the big sick patient in the first hours. What I'm talking about today may seem very simple to you, but I think this topic addresses some important points. Among them, the ability to question dogmas that we often apply without thinking, the need to use a very precise word when we talk about physiology and pathophysiology, and finally, that without taking risk, I think any innovation is impossible. It all starts with this publication of Mendelssohn. He is the first guy talking about inhalation of gastric content in the context of induction of anesthesia. This continues with these three publications in the early 15 when with the use of succinylcholine in humans, and the master publication of Selick. What is interesting to note is that from this old study, the majority retained only one of its conclusions, that the compression of the esophagus avoids the regurgitation of stomach contents during induction of anesthesia. His second conclusion often go unnoticed, even though it may be even more important than the first. Its maneuver prevents gastric distension from positive pressure ventilation. And Willie is the first in 1963 to encourage not delivering positive pressure while waiting for curarization. When I say rapid sequence intubation and ventilation, what do you think? I'm sure it's about regurgitation, but not only. We can see also all of the following: pulmonary aspiration, gastric distension, difficult intubation, severe hypoxia, oxygenation versus decarboxylation, emergency call to ENT surgeon, cricothyroidotomy, and death. I can give you some facts and number about regurgitation. It's interesting. Incidence of regurgitation is between 0.01 to 0.1%. In this recent review, incidence of gastric regurgitation with pulmonary aspiration was 0.01%. Mortality of pulmonary aspiration was 0.002%. And when it was an emergency procedure, the risk was 30 times higher. In his life, an anesthetist will face gastric regurgitation with pulmonary aspiration between 4 and 40 times. Facts and number about desaturation are even more informative. Incidence of SpO2 less than 92% during adult anesthesia induction is almost 1%. Incidence of SpO2 less than 90% during RSI is between 30 to 50%, almost 1 in 2 patients. And incidence of cardiac arrest due to deep hypoxia during RSI is 2%. This is mostly ICU patients. I think it's important, as I told you in the introduction, to use precise words. When we talk about positive pressure respiration, we talk about oxygenation and ventilation. Oxygenation, what determines oxygenation is FiO2 and positive and expiratory pressure, or PEEP. And when we talk about ventilation, in this context, we talk about decarboxylation determined by tidal volume and respiratory rate. What we are really looking for while performing what we are really looking for while performing RSI. Is it oxygenation, decarboxylation, or both? What we are looking for is oxygenation. As we will see, ventilation is not so important. And why some patients quickly desaturate during laryngoscopy while others not? Because of physiological change. In this diagram, you can see the relationship between the percentage of physiological shunt, the FiO2 and the PaO2. When the shunt is greater than 25%, which means that more than 25% of the lungs are collapsed full of pure edema, and deoxygenated blood passes directly through systemic circulation, there will be desaturation regardless of your FiO2. We have to fight the shunt, to fight atelectasis. And the antidote to atelectasis is positive pressure, especially PEEP, which recruits, but above all, avoids alveolar derecruitment. We can return to our original question, ventilation or not, or more precisely, application of positive pressure or not. This is a rough debate for decades without robust evidence until this study, published in the New England Journal of Medicine in February 2019 by Kazé. The topic of the study was the interest of positive pressure ventilation with the gas mask device during the apnea phase of RSI to decrease the risk of severe hypoxemia, not to show safety outcomes, but to decrease the risk of severe hypoxemia evaluated by the SpO2 method. In 2 words, they use a bag mask device with a PEEP valve. The outcome, the primary outcome was the lowest SpO2 observed. The secondary were incidence of severe hypoxemia defined by SpO2 less than 80%, occurrence of pulmonary expiration, which occurs in massive regurgitation, and occurrence of new opacity on the chest radiography in favor of passive regurgitation unnoticed by the intubator. You can see that in this study, all the results were significant. There are much lower saturation in the no ventilation group, with more than 20% of the patient saturation dropping under 80% and 10% under 70% in the no ventilation group. For the primary outcome, higher minimum SpO2 in the bag mask ventilation group, much significantly lower risk of severe hypoxemia in the bag mask ventilation group. And for the safety outcome, the results are even more striking. No more tracheobronchial inhalation or passive regurgitation in this bag mask ventilation group. This is a multicenter pragmatic trial with a large number of patients. This study had the merit of existing and bringing some logic to the debate on ventilation or non-ventilation during RSI. Hypoxia during RSI is much more common than regurgitation. The lowest incidence of hypoxia is 30%, when the highest incidence of regurgitation is only 0.3%. Hypoxia is 100 times more riskier than regurgitation. Respective mortality rates are 2% versus 0.06%. So hypoxia is 33 times more deadly than regurgitation. So the question is not should we deliver positive pressure during RSI, but is how to best deliver positive pressure while limiting the risks. That's the first question. What is important is oxygenation, as we already said. What about decarboxylation? This graph showed the increase of PaCO2 in absence of ventilation versus time. In a fully apneic patient, the PaCO2 will increase by only 0.25 kilopascal per minute. In the Kazé study, the median apnea time was about 2 minutes, so PaCO2 would increase if we did not ventilate only by 0.5 kilopascal. With this information, we can say that tidal volume during this continuation of oxygenation should be low or very low. The question of ventilation or tidal volume during this time could be therefore resolved by considering the pathophysiology of tracheobronchial inhalation and its protective factor. Esophagus is not a simple pipe connecting the pharynx to the stomach. There are two one-way valves, the upper and the lower esophageal sphincters. This one-way valve can be deactivated by the distension of the esophagus, which induces a reflex peristaltis, aiming at releasing the esophageal contents toward the stomach or the pharynx. First case, I swallow. Second case, I vomit. There are three mechanisms of regurgitation in this consent when we are applying soft positive pressure: transient increase in the gastric pressure, reduction of the lower esophageal sphincter barrier pressure, or complete relaxation of the lower sphincter. Does gastric gas insufflation cause regurgitation? It leads to relaxation of the gastric wall. That's a good thing. But also relaxation of the upper and lower esophageal sphincters. Not a good thing. We don't know the effect of our anesthetics, hypnotics, and opioid on these adaptative mechanisms. So we must remain cautious and leave ourselves a safety margin. What we know is that curization does not affect the lower esophageal sphincter, but does affect the upper one. The upper sphincter barrier pressure is 15 centimeters of water with curization, so the risk of gastric insufflation of gas is when this pressure is above the 15 centimeters of water. What is the optimal inspiratory pressure during RSI? There is no clear answer possible, but the minimal pressure will be the safest. Less than 15 centimeters of water for sure, so 10 even more, because it gives us this safety margin in order to deliver a PEEP, because it's oxygenation that matters and not decarboxylation. When we talk about oxygenation, we have to talk about mean airway pressure. The determinant of mean airway pressure are the pipe, positive inspiratory pressure, the PEEP, positive and expiratory pressure, and the inspiratory time. The mean airway pressure is the area under the curve of this pressure versus time graph. To increase the mean airway pressure, we can increase the pipe, increase the PEEP, or extend the inspiratory time. We will see from this video coming from EMCRIT blog, these are lungs whose trachea have been intubated. In this third video, you can see that they ventilate the lungs without a PEEP valve. And on this diagram, you can see that they will give high tyndall volume without no PEEP. And the area under the curve here, the area under the red line, which is the map, is very low. So oxygenation is not optimal. High tyndall volume, the lungs are fully emptied at the end of the exhalation, promoting shunt, atelectasis, and deoxygenation. In this second video, they install a PEEP valve, and you will see that with this PEEP valve, the PEEP is higher for sure. You can give only small tidal volume, and the area under the curve, it's much higher, so the oxygenation will be better. And you will see that the lungs remain open, even at the end of the expiration, with quiet, lower tidal volume.
Which is why the lungs are staying. So they stay inflated much longer.
What I present here to you, it's what I call anesthetist skill and strategy, because I'm now an anesthetist, I'm working in the operating room, and after this presentation, maybe we can call this strategy continuation of oxygenation to the big sick patient. We use our anesthesia ventilators features, and for the pro-oxygenation in a spontaneously ventilating patient, we put some PEEP by closing the APL valve to recruit some FRC. When he loses his spontaneous ventilation, we continue oxygenation using the bag with an APL valve set at 10 centimeters of water only, in order to give a minimal VT while maintaining a PEEP, without completely releasing the pressure on the bag at the end of the expiration. 4 hands in a perfectly positioned patient with a Guedel cannula in place. The pre-oxygenation here, we put the Gedel's cannula here, APL valve set at 10. You can see here the wrong way to apply positive pressure while while waiting for coagulation with high tyndal volume and no PEEP. High tyndal volume almost 400 millimeters. Here, the transition between the wrong way and the good one with an area under the curve much optimal. Here the same, and during 5 minutes, no desaturation. Here, a short video only to show you how we cannot releasing the pressure on the bag to give some PEEP at the end of the expiration. One thought before the conclusion. Is this evidence sufficient to go ahead and apply positive pressure during RSI? I think it is. Why? CASE needs 400 patients to show a reduction in the occurrence of severe hypoxemia in this study, with a 100 times lower risk for regurgitation. I'm not a statistical expert, but I think we need almost 40,000 patients to show this safety outcome. We have clinical practice and experience, pathophysiology, secondary evidence on our side. Should we thoughtlessly apply a precept put forward by Willie in 1963 when we know that the risk is multiplied by 133? You have to make an informed choice. I did mine. Take-home messages, it is possible to bag mask during RSI. Major risk of RSI is severe hypoxemia. This study provides some robust arguments. We need to be precise when we are talking about physiology. Continuation of oxygenation is not ventilation. We have to know pathophysiology of tracheobronchial inhalation to perfectly fit our ventilation or continuation of oxygenation in this context, and we have to practice. First in the OR, then on the big sick patient. And you can see that I'm not talking about apneic oxygenation in this context. I place myself in the context of the big sick patient in the emergency room, intensive care unit or pre-hospital setting. I've been training to this strategy for almost 4 years on elective patients, fasting well, easily pre-oxygenated in the operating room with all the emergency equipment at disposal. But when I have to deal with the severely hypoxemic patients, I am perfectly trained to apply this positive pressure strategy in a safely manner. Thank you very much.
Thank you, sir. Really, really informative. Now, I will go to questions from you, so get your questions ready. But I want to say just one point you picked up at the end there about apneic ventilation. Now, one of my hats is I'm a difficult airway anaesthetist in London at Guy's Hospital. And we use Thrive a lot, and high flow. And I was thinking of Domagoj's pants analogy, and it's like, I use Thrive on everybody. It is definitely a very, very favoured toy. Is this something we should be considering to use for this group of patients? Is something that every resus bay should have? Maybe in the future, even ambulances should have?
My point is that we have to use Thrive for most of the patients when it's available. In this case, maybe sometimes it's not the case in the emergency room. It would be intensive care unit in the middle of the night, maybe not in hospital setting. With Hamilton respirator, we can do this right now, but I think it could be difficult. It's not to say, okay, don't do Thrive and do this, but in case or when apneic oxygenation is not available, I think it's a good thing to reconsidering the way we apply positive pressure and not saying no ventilation during RSIs, because I think it could be dangerous. When you know that your patient will be hypotensive after your induction, you give him noradrenaline before the induction. I think it's the same. We don't accord sufficient importance to the hypoxemia after the induction when it don't bring the patient to the cardiac arrest. But I think it's very, very important to consider this and not say, okay, it's RSI, so absolutely no ventilation. Okay, no ventilation, but application of positive pressure.
And absolutely, and I think it's one important differentiation there to make between having nasal cannula on 15 litres versus something like Thrive on 60 to 80 litres, where the evidence base is very much towards Thrive rather than the former.
Absolutely.
Any questions? A couple there, but the runner is coming to you. Just keep your hand up so you can see where to throw the mic.
Thanks for the talk. As I understood the New England Journal publication, there was one big problem. It was the USA ICUs, no anesthesiologists, and the first pass success rate of only 80%, which is, as an anesthesiologist, it's not a good
Absolutely.
rate.
I think for the anesthesiologist, I think this talk can be applied when we take care of very severely hypoxemic patients. They are the same patient that the ICU patient. But when I'm talking about this is only ICU patient, I think it's important to note that we have to train before to be confronted to this patient, and the operating room is a good place to do this. I don't know if it's a good answer, but that's the way that's the way I'm considering the things.
I think there was another question at the back.
Thank you for a great talk. So there are two comments I wanted to make. One is about atelectasis and positioning and PEEP. PEEP is great, and obviously COVID taught us we need PEEP in situations of ARDS. But in most of my patients, I think simple positioning, elevated laryngoscopy, or in the sickest of the sick, 45 degrees up, opens up so much of the airway. And people forget that when you lay people flat, you lose 40% of your tidal volume. After drugs, namely induction and paralytics, you've lost 60%. So if you are intubating patients flat or pre-oxygenating them flat, you're already starting behind the 8 ball. So I think that positioning needs to be emphasized, especially in the sickest of the sick. And then secondly, to Dr. Chatterjee's point about Thrive, in North America, coming off of the wall, if we take our oxygen cannula, a standard 50-cent cannula, the 50-cent cannula coming off of the wall, not the cannula that has the Untitled CO2, but the standard cannula, and we set it to, flush, jet speed, it will generate between 70 and 75 liters per minute. Now, that will cause serious irritation of the nose in about 5 to 15 minutes, about as uncomfortable as an IV over that period of time. In Australia, and I don't know if we have anybody from Australia, but the flush rates are about 40 liters a minute. I don't know what they are in the UK or in Europe, but transient use of a few minutes duration of taking a standard nasal cannula that you have in your emergency department can give you very high flow rates. And what I do in my practice is, if necessary, is I have a second, because I have the bag set up ready to go on one oxygen source, I have a secondary canister that I then run O's up the nose during and before intubation. But I was just curious if anybody in the continent or the UK has measured flush rates coming off the wall.
That's a very, very good point, and I think the flush rates have been looked at in the UK as well, and similarly off the wall in hospital, it is very high. The issue was when this was being translated into pre-hospital practice with an oxygen bottle with a few hundred litres in it, the regulator at the top would go to 15 litres, and you couldn't put it onto that high flush. And I've certainly heard that, and absolutely in the short term, that dehumidified oxygen is going to do good, not cause you a problem, and you wouldn't leave it running for longer. But I think that's a very important point to make from you. Question up here. We're making this run a run. And I have to say, that is one of the things I really like about this group of individuals here, is seeing the different practices and the different things around that catch you out sometimes.
Thank you. First of all, for the apneic oxygenation, maybe that's more of a question to you. Do you use that also in the operating room settings, or only in pre-hospital or emergencies or ICU?
I use it in theatre all the time. So with my difficult airway patients, we use Thrive all the time. It's made my lack of being a brilliant anaesthetist, covered up by this beautiful Thrive thing. Every time I screw up my sedation or my topicalization, the Thrive rescues me and gives me that 5 to 10 minutes to normalize things. It's fantastic. It makes me look really good.
Yes, the check graph on the increase of PaCO2 come from an apneic oxygenation with high flow nasal cannula, when the patient can be stay without desaturation during almost 1 hour. So it's in the operating room we use when we know that we will have some difficult airway management, or in the severely hypoxemic patient during the waiting for the catheterization.
And we opted out of that in our operating theaters because we rarely had desaturations, but we have been working a lot with pre-oxygenations, with pressures and positioning, especially in our obese patients. And we have apnea times of 5 minutes without desaturations when we do with our regular way, let's say. So we opted out of that in our operating situation. But we have it in the ICU setting.
It is. It's quite informative, isn't it? That we talk about these very, very complicated things, but actually getting the basics right, as you say, and doing these things and getting positioning and our simple things done correctly actually obviate the majority of the problem rather than reaching for something really, really complicated.
To the point that you were making with your study to ventilate during RSI, especially in the ICU, it was kind of the takeaway from the NAP4 study also, right? So, yeah, thank you.
Right. Well, thank you very, very much for such a well-attended morning session. There are 2 things to remind you of for this afternoon. So first of all, those not going up the mountain, 12:15 here for the world's best ultrasound workshop. For those of you going up the mountain, I would say never follow Ollie. It always leads to danger, but that's probably more later when you're in the bar. But when it comes to skiing, I'll let him talk to you.
So lunch options, you have a couple options. You have all the tourist traps on the Bahnhofstrasse. Now, everything is good, but you usually need reservations for more than 3-4 people. You can also go to Coop, that's that grocery store. When you walk out towards